Good morning and welcome back to the final day of the 2020 Us Against Alzheimer's National Alzheimer's Summit. I'm Russ Paulson, Chief Operating Officer of Us Against Alzheimer's, and this morning we're going to hear from two of our nation's leading voices on caregiving and public health, both of whom have new books. Dr. David Satcher is the 16th U.S. Surgeon General, former Director of the CDC, current board member of Us Against Alzheimer's, and Dr. Satcher has just written My Quest for Health Equity, Notes on Learning While Leading. Also, Diane Rehm, a nationally recognized NPR host, author of When My Time Comes, conversations about whether those who are dying should have the right to determine when life should end. Dr. Satcher and Ms. Rehm will share lessons learned from a lifetime of public advocacy around respecting the dignity of patients, individuals, and caregivers as people age. Yvonne Laddie, an award-winning journalist and caregiver, will moderate this discussion. Yvonne?
Hi, I'm Yvonne Laddie. I am a journalism professor at NYU and the graduate director of a multimedia program. But I think I'm here mostly because I'm the daughter of someone who is suffering from end-stage Alzheimer's. I'm a caregiver. And honestly, my mother's a Dominican immigrant. So it's been really rough. And I'm really honored to be able to be a part of this conversation with two really amazing people with so much to offer on all of this. Because the more we talk about end of life, the more we face it, the more we understand it, the easier, peaceful, and more celebratory that journey can be. I mean, one of the things I have experienced a lot in my mother's journey is just so much sadness and pain and anger and confusion. But when I think about the end of life, especially after reading Diane's book, I think it deserves to be so much more. So let me introduce the two people that are going to be speaking with me today. We have David Satcher. He is the 16th U.S. Surgeon General. He is a physician scientist and public health administrator with an extensive track record of leadership, research, and community engagement. Dr. Satcher served as the 16th Surgeon General of the United States from 1998 to 2002, and the 10th Assistant Secretary for Health in the Department of Health and Human Services, and that was from 1998 to 2001. He also served as Director of the Centers for Disease Control and Prevention and an administrator of the Agency for Toxic Substances and Disease Registry. And then we have Diane Rehm, who is an NPR host of On My Mind podcast, but I think a lot of us have heard her on the radio and in her own shows. She's had an incredible radio career that has spanned more than 40 years. The Diane Rehm Show featured on WAMU and NPR grew from a local program to one with international reach and a weekly audience of more than 2.8 million. Diane now hosts On My Mind, a podcast featuring conversations on the issues she cares about most: what's going on in Washington, ideas that inform, and the latest on living well as we live longer. Diane is the author of 4 best-selling autobiographical books and is a director emerita of the Penn-Faulkner Foundation and a trustee emerita of McDonald College. She was married to her beloved late husband, John Rehm, for 54 years. In 2017, she married John Hagerdon, a retired Lutheran minister. She has 2 children and 4 grandchildren. And thank you both for being here. Every time I read bios, I worry that I'm going to hack them because mine has been hacked so much when they've been read. But hopefully I did okay. And I just got to say, I'm so happy to be here with you both and get to talk to you about this.
Thank
I guess
you.
My first question actually is for you, Diane, because I am clearly a Black woman. My mother is Latina, so am I. And in your book, which talks a lot about, which really is about dying with dignity and dying with assistance, it's really clear to me that to do that costs money. And a lot of the people in my community don't have that kind of money to spend thousands of dollars on drugs to end their life. There's also a fear in communities of color. When you look at the amount of African Americans and Latinos who are involved in even things like clinical trials, the numbers are low because historically, especially when you look at the African American community, our bodies were used for experimentation. And so it seems like there was a disconnect to me. Like it felt like if you are wealthy and white, this is an incredible option. But if you're poor or working class and Black or Latino, you're just going to die. And especially in the Alzheimer's community, where could someone like my mother consent now? I mean, she doesn't even speak. How would you address that?
Well, let me address your three questions, really three. First, on money. A long time ago, the medication required to end one's life when Oregon, the first state to adopt medical aid in dying, came into being. The medication was very inexpensive. And then, as you may or may not know, that drug was taken from a cost of some $10, $20 to thousands of dollars. And then that pharmaceutical company sold it, and then it went off the market. We are now back to a reasonable cost for the medications that are used in medical aid in dying. Secondly, you're absolutely right about the mistrust on the part of people of color. I spoke for both the documentary film, which is coming out next spring, on which my book is based. I spoke with a pastor of an AME church here in Washington who said precisely what you've said. Why should anyone in the Black community trust the medical profession to do right by them because of experiments that go so far back to Tuskegee and the like, to making people feel as though they are less than human? He finally said, if you, Diane, could guarantee me that Black people would have as fair treatment as white people in their medical treatment throughout this country, then I would support you in medical aid in dying. Finally, in regard to Alzheimer's disease, I am so sorry about your mother. I must tell you that the laws regarding medical aid in dying in this country at this time do not include Alzheimer's disease because all of the lawmakers who passed these laws have felt that that goes one step too far. So I have taken matters into my own hands and have videotaped with my grandson a message to my family saying that should I begin to exhibit signs of Alzheimer's, I do not wish to go on, and I will end my own life. If the laws have not changed by the time I've reached that point, I will do as my husband did, my late husband. I will stop eating. I will stop drinking. I will stop taking medication because I do not wish to live through the suffering that your mother and your family are now experiencing.
Thank you. Dr. Satcher, your book is about leadership and the lessons you've learned throughout your life, from milking cows in rural Alabama to being our nation's 16th U.S. Surgeon General. What does leadership look like to you in the fight against Alzheimer's?
Well, I should say at the outset that my wife died in June of 2018, and she had suffered with Alzheimer's for more than 10 years. Her mother, before her, died in 2003 of Alzheimer's. So I've had this personal experience with Alzheimer's and the suffering that goes along with it. In my own life, of course, even though I've had those experiences with very close relationships, I haven't worked out any plan for myself, and I don't know to what extent Alzheimer's will be a factor in at the end of life for me. But I've had quite a life. I'm almost 80 years old and had a chance to practice medicine and do meaningful research. I've been president of 3 institutions, Meharry Medical College, Morehouse School of Medicine, and Charles Drew. I was actually CEO of Charles Drew before it became a university. And so I think what leadership has meant to me, because I have become leaders at times when there was a crisis or a significant need for somebody to step in and provide leadership. It was not because I sought leadership positions. In fact, in most cases, just as at Morehouse School of Medicine, my plan was to lead a department of family medicine. And then when I got there, the Meharry situation came up, which some of you probably remember, in the early 80s. And they were saying that Meharry was going to close. I'm not a Meharry graduate, but I was encouraged to at least go for the interview. And when I did, decided that it was the kind of thing that was too important for me to say no to. That's been the nature of leadership for me. I was on the way to somewhere and ended up going another way because of the needs and the importance of an institution. In Meharry's case, it's amazing that so many of its graduates had gone to practice in underserved rural or inner city communities and provided care to people who needed it most. The institution had taken care of poor people, many of whom could not pay for their care. And so it's been that kind of experience where I have not sought leadership roles. in most cases wanted to do something else and go somewhere else, but decided that it was important that I change my plans. So that's been the nature of leadership for me. There's a background, of course, I talk about in the book that started here when I was a student 60 years ago. The student movement here in the Atlanta University Center was started by people like Marion Wright, now Marion Wright Elman, but also in situations like the student sit-in movement, where the issue was, the right to eat at a restaurant, or the right of somebody to refuse you because you were Black. And so I ended up going to jail with other students here on 5 occasions. And I think that helped to shape me in terms of how I feel, what I believe. And I feel good about the fact that we were able to participate in changing not only Atlanta, but the South. And so that's been the nature of my leadership development.
Diane, your book has a lot of powerful stories and interviews with terminally ill patients, their caregivers. It's very, very moving. But what did you learn from these conversations?
Well, I learned that there are good reasons for people to have very different beliefs. I learned from speaking with a Roman Catholic priest how deeply felt his beliefs are, coming directly from the Bible. I learned from a physician in Oregon how strongly he disagrees with medical aid in dying, because he believes that the doctor's role is to go on the journey with the individual who is dying and to be with that person the whole time. However, I learned from a 37-year-old mother with breast cancer that had metastasized throughout her entire body. She said, "I'm dying. I know I'm dying. If I had my druthers, I would live to be 90. I don't have a choice. I am going to die. I do not want my 13-year-old son to see me in agony. I do not want him to see me suffer. So I am glad that I have control, a certain amount of control over the end of my life." And that is the one thing that every single one of these patients spoke of, having some measure of control at the end of life made them feel more calm, made them feel easier about dying, knowing that they could bring their own suffering to an end when they chose. The other question that was posed to me again and again, and may be in the minds of some of your viewers and listeners today, what is the difference between medical aid in dying and suicide? Why do we not refer to this as medical aid in suicide? because people who are dying have no choice. One who commits suicide has a choice to live or to die. Those who are dying have no choice. They know they will die. We worked on this film and I on the book, Yvonne, for 3 years. So I've learned a lot during that time, and I'm so thankful I have.
Before we go on, I just want to make sure that people know the names of your books because they are really profound and life-changing for anyone who's lucky enough to read them. Dr. Satcher's book is called My Quest for Health Equity, Notes on Learning While Leading, and Diane's book is When My Time Comes, Conversations about Whether Those Who Are Dying Should Have the Right to Determine When Life Should End. Dr. Satcher, what are your thoughts on medical aid in dying?
That's what you call throwing a curveball. I couldn't hit them very well when I was playing sports, but first, I think it's a very important topic. I can't think of a topic that's more important than that. And even though I spoke about my wife's death, because with Alzheimer's, people die differently. My wife was diagnosed with Alzheimer's 20 years before she died, in great part because her mother had suffered from Alzheimer's and had died from it. And so I must confess, never really dealt with the issue of dying the way Diane is discussing it. I know how important it is, but it was not something that we actually dealt with. My wife never expressed a desire to end her life. That doesn't mean that she didn't think about it. But obviously, I think I would probably deal differently with it in my own case, and if I have another experience with a very close personal relationship with one dying over a long period of time. My wife was very active up until about a year or two before she passed, and even though her level of activity and productivity changed over the years.
Yvonne and Dr. Satcher, I should be clear about what medical aid in dying is. Medical aid in dying, as written in Oregon and has been copied by 9 states plus the District of Columbia, permits medical aid in dying if 2 physicians have verified that a patient is within 6 months of death. Alzheimer's does not fall into that category, as clearly you have mentioned regarding the life of your wife. All kinds of safeguards are in place. In some states, a psychiatric evaluation is required to ensure that that individual is not being pressured by anyone in the family, and that psychiatric evaluation is done just one-on-one with no one else in the room. And I must say, doctors take this very seriously. Those who have agreed to become part of the medical aid in dying movement regard it as a calling, something that they are willing to do to help ease the suffering of a dying patient. But Oregon has now said that there will not be a 2-week waiting period between when those two doctors have certified that this patient is within 6 months of death and when that medication can be provided. Because in some cases, patients were dying within that 2-week waiting period. So Oregon has now done away with that. But I just want you to be sure to understand that right now, Alzheimer's disease is not an issue upon which doctors can make a decision to allow medical aid in dying. I, for one, hope that someday it will be included because the suffering of patients and their families over many, many years can be, I've seen it myself, and it can be just horrific. So I just wanted to jump in with those thoughts.
Well, that's really helpful to hear.
So,
It's really complicated for me because I feel like if my mother was in her right mind, she would not want to live like this because she is no longer herself at all. I mean, she's completely unrecognizable, and all the things that made her who she was, Alzheimer's has taken away. And so as a daughter of an Alzheimer's patient, even though my chances of getting the disease are low, it is still slightly higher than the rest of the population. And it makes me think, like, would I want to put my daughters through what I've had to go through? When what I've gone through is something I wouldn't wish on my worst enemy. In many ways, my mother doesn't know what's going on, but I see it all and I experience it all.
Yes.
And the dignity of the death is lost in Alzheimer's. So, but it's complicated because the person, you would have to do it immediately at diagnosis, and then everyone's journey in the disease is so different.
right.
Well, not necessarily immediately at diagnosis, but that is why I taped that message with my grandson. And while he was taping me on his iPhone, the videographer for our film was taping the two of us as we had that conversation. And I did so because I want my family, I want my friends. I've already spoken with my doctor. I want them all to know that should I receive that diagnosis and should it begin to progress, I need their feedback as well as my own feelings. I, like my husband, who ultimately died of Parkinson's disease because he had lost all sense of dignity, decided to stop eating, to stop drinking, to stop taking medication. It took him 10 long days to die. He was a totally sound mind, but he was in a nursing home in Maryland, which did not then and does not now allow medical aid in dying, which was what John Ream so much wanted for himself. So the goal of this documentary and this book is to begin the conversation, to encourage families to talk about what it is they want at the end of their lives. It's not one conversation. It's not an easy conversation. It's many conversations over a great deal of time. And I hope both the book and the film will encourage people to have it.
Okay, we have some questions from the audience. The first one goes to Dr. Satcher. Did you learn leadership skills while caring for your wife, or did your existing leadership skills prepare you for that unexpected role?
Well, I think the answer is yes, that I learned leadership skills because I had not been in that position before. And so I think I'm better able now to support individuals and families who go through the same kind of experience that we went through. And that's so in that sense, I would say, yes, I learned leadership skills because I learned a lot about the needs of people experiencing Alzheimer's, but also how to make the best of that experience. That can be devastating.
All right, the next question is for Diane. How do you talk to people about this who are opposed to the notion for religious or cultural reasons?
Well, I think you don't talk to them, rather you listen with them. I think that engaging with people, expressing your own views, but listening very, very carefully to their views is more important than the talking you will do. I can express my own experiences. I can offer examples, but one legislator said it best. He said, you know, we are all just one bad death away from supporting medical aid in dying. Seeing that kind of suffering, seeing that kind of misery that I saw in my husband when he said, I can no longer feed myself, I can no longer stand on my own, I can no longer toilet myself. I have lost all dignity, and if I stay alive, I will go more deeply further into indignity. And I said to him, sweetheart, are you sure that this is what you want to do? Do you really want no more food, no more water, and no more medication? And he said, I am absolutely certain. And he was.
Wow. Okay, the next question. I also just want to say, like, I so appreciate how honest and real you both are. For anyone out there who's going through what I'm going through, it feels very supportive. Like honesty and truth just feels almost like a hug. And it makes people like me feel like we're not the only ones who have gone through such hardship. Because sometimes you do feel like it's just you.
I wish
I
I could
know.
right now, Yvonne. I really do. I wish I could hug you now. I do understand, and I feel very much as though I'd love to give you a big hug.
Thank you. I'd love to give you a hug too. And you too, Dr. Satcher. I'd love to give you a hug too. But I have a question from the audience for you. Dr. Satcher, what leaders have influenced your life and journey to improve health equity?
Well, in the book, I start off with my parents because neither of my parents finished elementary school. My mother went to the 5th grade. My father dropped out in the 1st grade. But I talk about how exemplary they were as parents in raising 9 children on a 40-acre farm. And my dad went on to become superintendent of a Sunday school. And my mom would always make sure that if we had food and the neighbors did not, that we would be going back and forth taking food to those neighbors who didn't have it. I learned a lot from them because it's not easy to raise 9 children. And I think they did a great job. And that has contributed significantly to my life and my work and my leadership roles, I think, too. So most definitely it started there. But I was fortunate also to go to Morehouse College when Benjamin Elijah Mays was president, and anybody who knows that name know that he's just a model of exemplary leadership. Spoke to the students every Tuesday morning, and there are a lot of quotes that I still use a lot from Benjamin Elijah Mays. I also came at a time when Martin Luther King Jr. was still alive. He was a graduate of Morehouse College. He spoke there at least once a year. And I went to Ebenezer Baptist Church when he was co-pastor with his father. And of course, even though I was not in Montgomery during the Montgomery bus boycott, my brother was at Alabama State College during that time, and so I experienced it through him. But again, learning through suffering in a way. A.D. King, Martin Luther King Jr.'s younger brother, taught me a lot about leadership too. He, when we were getting out of prison, 5 of us went to prison because we had succeeded in filling the jails in Atlanta. And as we were getting, and there was a young white man who sprayed us with spray when we were sitting at the counter trying to get served. So when the police came to arrest us, they had to arrest him too. And I never will forget A.D. King, when we were being let out of prison, suggested that we ask them to let this young man out also. And most of us were opposed to that. And A.D. King said something that I've always remembered. He said, nonviolence is not just about not hitting, it is about not hating. And that's what we have to exemplify in asking that this young man be let out of prison. So we did. And but it taught me a lot that it's one thing to preach it, it's another thing to actually experience it and lead in that way. So I was fortunate to learn a lot from fellow classmates. I was a pre-med student, so obviously I believe of all the people who worked in the movement, I was the only one that was a pre-med student. But I knew that I had to do well academically just as the other pre-med students. And I was fortunate enough to be able to do well. I could also say a lot about medical school, but you don't want to hear about that. Okay.
I mean, I find your life so inspiring, and I wish so many young African Americans can hear you and see how you have persevered and have succeeded. I mean, you're one of those heroes, sort of the heroes that we don't hear enough about. So thank you for everything that you have done. It's like, especially today, you know, when things are so difficult, it's so inspiring to hear from an African-American man who succeeded through such, you know, incredible history, really. So I have one question here for Diane. It's probably gonna be the last question. We have 3 minutes left. It seems important to put your wishes for end of life in writing while you are young enough that you are of sound mind. Any suggestions for ways to approach that?
You know, I did do exactly that, and Anne Morrow Lindbergh was my example. In her book about her mother, her daughter, after Anne Morrow Lindbergh died, found a note that her mother had left stating exactly what she wanted. She wanted not to be kept on any kind of machine or have her life extended beyond any reasonable hope of full recovery. And I think that that's what too many of us lose in our thinking about end-of-life issues. When the doctor says, well, we could do this or we could try this, think, is that really going to give me my life back as it was? Am I going to be fully the Diane I've always been? Or is it just going to be 3 more months of suffering, which to many people might be worth it? Some people believe that God should be the only decider. I support them 100%. Others want everything medical science can provide. I support them 100%. And I would like the option for medical aid in dying. And I hope you will support my desires as well.
Well, that's a really powerful way, I think, to end our conversation. Like I said before, this has been really an honor for me. I feel like I learned so much and that there's a lot for me to think about in moving forward within my own life. And I think that that's all anyone can hope for, is have the information, embrace it, learn from it, and then make your own decisions.
Exactly.
So thank you both.
Thank you.
Stay safe. And it was wonderful talking to you both.
Thank you so much.
Oh, and everybody out there, buy their books. They're incredible. And like I said, it's something that I think about all the time. And we need to be thinking about these things. My Quest for Health Equity, Notes on Learning While Leading, And Diane's book, When My Time Comes, conversations about whether those who are dying should have the right to determine when life should end. Thank you both so much.
Thank you.
And next up at the 2020 National Alzheimer's Summit, we have an exercise break brought to you by our friends at Curves. We hope this helps to keep your brain fit throughout this great content.
Forward lunge. Start by standing with your feet hip distance apart. Place your hands on your hips. Step 1 foot forward. Bend your knee and lower into a lunge. Be sure your knee stays in alignment with your ankle. Now switch sides. Keep your back leg straight as you press your heel into the ground to stretch your calf. Take a deep breath, and as you exhale, deepen the stretch.
Change stations now.
Hamstring stretch. Place one leg slightly forward with your toe pointed up. Bend your other leg and lower your hips back and down. Place your hands either on your thigh or on your hips for balance. You should feel this stretch from your hip to your heel on your straight leg. Now switch sides. It's important to keep your chest and head up as you stretch because your heart rate is still elevated from your workout.
Change stations now.
Quadricep stretch. Lift one foot up behind you and grasp your ankle or the top of your foot. Gently pull your heel towards your bum. Be sure to keep your knee directly underneath your hip. Switch sides. You can either place your hand on your hip or bring your arm up off to your sides at shoulder height to assist with balance. You can also place your hand on a wall, countertop, or sturdy chair.
Change stations now.
Chest stretch. Stand with your feet hip distance apart. Lift your arms up off to the sides at shoulder height. Now reach each hand out toward the walls. You should feel this stretch across your pectorals, deltoids, and biceps. Stretching after a workout helps prolong the benefits of your workout. This includes prolonged calorie burn, so keep stretching.
Change stations now.
Side upper back stretch. Begin with your feet hip distance apart. Raise your right arm up overhead, then slightly bend towards your left. You're stretching your triceps, latissimus dorsi, and obliques. Now switch sides. Raise your left arm up overhead and bend to the right. You should feel this all the way down your side.
Change stations now.
Tricep stretch. Place one hand behind your neck and raise your elbow up toward the ceiling. Use your other hand to apply gentle pressure to your elbow, pushing your arm down so your hand touches your shoulder blade. You want to hold this position for 15 seconds. Now switch sides. It's important to stretch both the right and left sides of the body equally. It's also important to stretch both the front and back muscles. This ensures that you're creating body symmetry.
Change stations now.
Open chest stretch. Clasp your hands behind you and pull your hands away from your hips. If you can't clasp your hands together, that's okay. Reach back as far as you can. Make sure your shoulder blades are pulled down and back to avoid shrugging. Make it a goal to do this stretch a few times a day to improve your posture.
Change stations now.
Standing side stretch. Start by standing with your feet shoulder distance apart. Cross your legs at the knees by placing your right foot in front of your left. Raise your left arm up overhead, leaning slightly to the right. Hold this stretch. Now switch sides by crossing your left foot over the right. Raise your right arm up overhead and lean slightly to the left. Notice any muscles that might feel tight as you hold this stretch. Take a deep breath, and as you exhale, try to deepen the stretch a little.
Change stations now.
Upper body stretch. Stand with your feet about hip distance apart. Raise your arms up overhead and clasp your hands together. Lift your torso up off your hips to elongate your spine. Focus on your breathing as you hold this stretch. You've completed a great workout. Think about how your body is getting stronger and more flexible every day.
Change stations now.
Outer thigh stretch. Sit on the floor with both legs stretched out in front of you. Bend one knee and cross your foot over the straight leg. Gently grab your knee and pull it towards your chest. You should feel this stretch in your outer thigh and glutes. Now switch sides. Keep your shoulders pulled back and sit up straight as you hold this stretch.
Change stations now.
Seated hamstring stretch. Sit on the floor with one leg straight and one knee bent. Reach forward towards your toes until you feel a nice deep stretch in your hamstrings. Hold this for 15 seconds and then switch sides and repeat on the opposite leg. Stretching after a workout helps increase joint mobility as well as decreases stiffness and soreness after your workout.
Change stations now.
Butterfly stretch. Sit on the floor with both knees bent with the soles of your feet together. You want to gently press your knees towards the floor. Place your hands either on your calves or your ankles. You should be feeling this in your adductors, which are your inner thigh muscles. Keep your shoulder blades pulled back and your head up to avoid slouching.
Change stations now.
Piriformis stretch right side. Begin by laying on the floor with your legs extended out in front of you. Bend your left knee and place your left foot flat on the floor. Lift your right leg, bending your knee and placing your ankle across your left knee. From here, lift both legs. Place your hands behind your left knee and gently pull your legs towards your chest. Take a deep breath and exhale. Try to pull your legs a little closer. You can do this stretch from a seated position in a chair as well.
Change stations now.
Piriformis stretch left side. Begin by laying on the floor with your legs extended out in front of you. Bend your right knee and place your right foot flat on the floor. Lift your left leg, bending your knee, placing your ankle across your right knee. From here, lift both legs. Place your hands behind your right knee and gently pull your legs towards your chest. Take a deep breath, and as you exhale, try to pull your legs a little closer. You can also do this stretch from a seated position in a chair.
Change stations now.
Hi again, Russ Paulson with Us Against Alzheimer's. The COVID-19 pandemic has upended nearly every part of our lives: school, work, how we interact with family and friends. For some families, it's done so much worse than that. It's also affected how our government works and how our elected officials and their staff interact with constituents. And so that affects how we can advocate. And we know that advocacy is critical. It's the only way, really, we are going to move the country to a brain healthier future, to one with faster cures because we invest more in the research, for health equity, and for access for all. The importance, the urgency hasn't changed. In fact, maybe it's gotten worse with COVID. But how we do it has to change. And that's why we've brought together policy and advocacy experts today to help you think about how to advance your Alzheimer's policy agenda in these challenging times. That discussion is led by our Chief Government Relations and Policy Officer, Niles Godis. Niles?
I am Niles Godis, and I'm Chief Government Relations and Policy Officer at Us Against Alzheimer's. We are here today to talk about brain health advocacy during the pandemic. Many of you have told us that you are interested in advocacy, even during this difficult time, and want to make a difference by educating your representatives on key brain health issues. So we have put this session together to ensure that you have the tips and information you need in advocacy during COVID-19, including a toolkit that can be found on our summit website. Today, you will hear from advocacy and policy experts about the ways that you can help build a brain healthier future through advocacy. We'll hear from Susan Emmer, Brian Hess, Stephanie Monroe, and civil rights icon Dolores Huerta about the importance of advocacy. Sue and Brian have worked with dozens of clients through the years, including Us Against Alzheimer's, to help them advance their agenda in Washington, D.C. And recently, they have had to learn to do this during the pandemic, and they will share these lessons with us today. Sue, over to you.
Thank you, Niles. Thank you, Brian. I am going to talk about the nuts and bolts of virtual advocacy during this time of COVID. And the first slide is sort of your schedule of what we'll be talking about during this next just under a half hour. I'm going to first start with a brief discussion of how Congress works. I'm going to move then into your different roles on the Hill, very specifically as a constituent. We're going to talk about really the primary goal of the training today and what we hope you'll be doing, and that is relationship building. We're then going to talk about the different structures of the Hill offices which you might be interacting with. We're going to talk probably multiple times about something today. It's an important point I want to make over and over. Are meetings political? And I'll start now, but you'll probably hear this multiple times. No, they are not and never should be political. We'll talk about general Capitol Hill etiquettes, just some tips for meetings, and then with some specificity, how the meetings requests go and what they might look like when you have them. We're going to take some time to talk specifically about doing advocacy during the COVID-19 environment as a constituent and how you'll follow up. Then my colleague Brian Hess will talk about it that we've developed for your use, which will be available to you. And then there'll be 2 slides on the specific issues that we'll be asking you to cover in your meetings. Next slide, please. Right, so just starting here to talk a little bit about the different bodies, the House and Senate compared. The House rules basically are very tightly controlled. This allows the majority party to really script the process in committee and very specifically on the floor. So that when something comes to the House floor, there's not a lot of room for members to try to change it or offer something different or proceed in any different way. The Senate is more open. I wouldn't say it's completely open, but by design, our founders have allowed the Senate to have more debate, more ability to come to the floor and offer amendments. And really what this does is allow for more consensus building and even working across the parties. As you all know from your civics classes and common law classes, to enact a law, the House and Senate must both agree to that same bill. And then the president has to sign or veto the bill, creating a law. One of the things that we want to mention here for you, because you may find it in your meetings, often you may have a different experience with staff, varying by the bodies, and then also by what committees that their member of Congress or senator sit on. The one thing in general you'll see is that the staff tends to be young. I always tell folks, don't let this in any way concern you. I was once a young staffer. I think most of us here were as well. And they're very hardworking and bright and do a great job. And in many ways, you're going to get more done even with the staffer than the member of Congress. The Senate staffers tend to be a little more experienced, perhaps a little more seasoned. And of note, if you do happen to be meeting with an office where those members are on the committees of jurisdiction, I'll talk a little bit more about this, then you'll most likely have a staff person that's more educated on your issue. And for instance, we're going to talk later about the Change Act, which is governed by the Senate Finance, and then the House Ways and Means, Energy and Commerce committees, and then paid leave, which is the labor committees. If you are dealing with a member that sits on those committees, you'll very often find staff who are probably more aware of legislation and issues pertaining to those committees. Okay, Brian, I'll go to the next slide, please. All right, just talk a little bit here about legislative process. One of the overarching functions is the budget process. The administration, the president, introduces the budget every year. That is non-binding. Congress is not required to follow that. Typically, there's a budget resolution, although that doesn't happen every year. But that's a function, sort of the grant Congress has to deal with, and not really anything we're asking you to deal with today. The next very core function of the Hill is the appropriations process. That is providing funding to the various agencies to do their work. And this is something that has to happen every year. It happens in a variety of ways, through individual bills, or more likely, because of the way the process unfolds, as larger packages where items are bunched together so that it's easier to achieve consensus and get them through the process. The third area to talk about, and this is really the two issues we'll talk about today, and these are the authorization bills. These are policy items, changes to policy that Congress does. And so, for instance, this is where Congress is changing Medicare policy, or might be changing other things. And one important point to make, I've made this already a bit, in the old days, and as I always like to say, in the schoolhouse rock days, for those of you that learned that way, the approach to making a bill was, it was introduced, there were hearings, it went through the bodies, marked up, etc., and moved on its own. And that happens very rarely these days. This is relevant because the opportunity to move things is harder. They typically happen in large packages where you have to achieve a consensus and then attach something to that package. All right, next slide. All right, so now we're going to move into the meat of this and talk about your different roles on Capitol Hill. One of the important points to make, Congressional Management Foundation, which is a nonprofit entity that studies Congress and actually polls staffers and members on what are the best ways of doing advocacy. They have found time and time again that constituents are a very valuable and important part of the process, of the decision-making process. And I think we can't overstate how important your role is. In a way, it really is the cornerstone function. I always tell folks, the folks on the Hill would much rather hear from you than from me. I'm an advocate, a lobbyist, and instead you are, a really real-life person. It's important for you to understand that you wear multiple hats when you have these meetings. They're all important. You're in there as someone telling a real live story. So it's so important that you say who you are and then why you're there. You're an Alzheimer's patient, you're a caregiver, you're a provider. Then you're also a voter and a taxpayer. This is not a political point. Again, your meeting should not be political, but you're a voter, and you don't have to remind anyone of that. It's very much known, and all this really makes you a constituent. So it's the job of Capitol Hill to hear from you. They want to hear from you. and they need to hear from you. So you should feel very empowered and important in that role. Next slide, please. All right, so I said this earlier when I introduced this, but really the major goal of what we're asking you to do and trying to give you the tools to do is to build a relationship with staff, members of Congress. And like any relationship you might have, it takes time. So it would not be realistic to think you're going to necessarily develop it from this meeting. That could happen, and it'd be wonderful if it does. But really, I think you should set realistic goals for yourself, that you're starting the process. And like with any relationship, you need to build that, foster it, and really stay in touch. And I think this is particularly important in COVID. You're always going to be looking for new ways to foster that relationship. The ways we used in the past aren't necessarily as available or even available at all. For instance, in the past, we would be asking folks to do in-person meetings and or to call folks directly. And those are two avenues that are just really not open right now because of COVID. But the important point to make is that there are other ways to do this. And some of these are using email. Email is critical in this virtual world for all of us, and it's very much so here. Virtual town hall meetings. And one of the items that has come up, many members are doing regular COVID sessions with constituents. I know many members are doing these on a weekly or monthly basis to hear from various constituents in categories as a way to understand how things are happening with COVID. So these are the type of ways that you could get in regular contact with members, develop yourself as a credible resource, and really then look to stay in touch in the future. And again, this is all happening by virtual ways, Zoom and other platforms. One of the points I'm probably going to make multiple times, and it's important for you to know, is the Hill is very COVID focused. Maybe this is down one click from when it first started, but you know, in the work we've done, we've at times had difficulty getting folks to go beyond COVID, or we have to kind of weave our way in there. I wouldn't be concerned if you feel that way. I would just, where you can, try to weave in any COVID experiences into your conversation as they relate to Alzheimer's. And I think this will be particularly something you can do as it relates to leave, but presumably it affected the last 7 months, and there were ways to do that. And I wouldn't, again, be concerned about it, but just aware if that comes up. All right, next slide, please. All right, I'm going to briefly talk here about the different offices, DC versus district offices. The Washington, every member of Congress has a Washington, DC office. This is where they can conduct their legislative business, they do policy, and their staff are typically the policy experts here or scheduling press. And presumably you'll be trying to make a meeting with these folks. Every member, of course, has at least one, if not more, district or state offices, which tend to focus more on casework and constituent services. And I always advise folks to develop relationships in both places. The DC office is more important and relevant to the kind of work we're doing here, we're talking about today. But often if it's easier, you may know someone because you live in the same place, and it may be a way to get into the DC office. So there's nothing wrong with having contacts with both offices. But again, just know that the staff roles differ in these offices. And if in fact you end up talking first or at points to the district folks, they're maybe not going to be as aware about the legislative items and may have to pass your issues on or refer you. All right, next slide, please. All right, I've referenced this already. I told you I'd talk about it over and over. It's a really important point. Our meetings political? They are not. Please keep politics out of your meeting. We have the great fortune of having a bipartisan, nonpartisan issue in Alzheimer's. Our goal is to keep it that way. And there is just no need to talk about politics. Talk about who you voted for, who you plan on voting for. It's just not relevant or appropriate to come up in these meetings. Next slide, please. All right, I'm going to give you some tips, talk a little bit about Capitol Hill etiquette. a lot of this stuff is really, not rocket science and very much related to the way you would probably conduct any meeting or relationship. One of the things to know is the Hill is a busy place. It's even busy in this virtual environment. Hill staff time and member time is limited, so try to make the most of it and be aware of that. You may have as little as 10 minutes for a call, up to 25 minutes, but I wouldn't be concerned if your meeting is short or it appears that someone doesn't have time. The staff and members are incredibly busy. They talk to constituents all day. There are times where they have 10, 15 meetings back to back. That's the context. So, just understand that and know that sometimes a short meeting can be the most successful one because they may say, well, I'm planning to support the bill you brought up, or it'll open the door to further discussion. So, I would look at quality over quantity here. If there's more than you, make sure that everyone in the group introduces themselves quickly, says their name, says where they're from, which I didn't say that earlier, but that's a very important part of your constituent relationship, making that point, as is, any other personal connection you may know about with the office. Talks about their experience with Alzheimer's as well. And it's very important that you, in your meetings, kind of deal with this like any elevator pitch approach, where you go in knowing what you want to do and kind of keep going back to that, even if you get pushed off it. The Hill can ask a lot of questions at times, or they may bring up something that's not related. That happens quite often. It's your job to kind of appropriately steer it back to the issues at hand. One of the things I always advise is, if there are multiple individuals in a meeting, try to schedule who is going to cover what in a meeting, so you're not looking at each other. It's particularly awkward in a virtual environment. At least in person, you can liaise on each other. So I think it's critical that you know who's going to do handoffs to issues, who's going to talk about specific issues if there's more than one of you. And make sure you leave time for Q&A and closing. We want to know also what staff thinks. So, make it interactive and make sure you have that back and forth. And, as I said before, practice, talk about roles, and we're going to talk about the two specific items to bring up, these topics. But the Hill is always at its best when you come in with specific things and actions for them to take, and we're going to equip you with those. Next slide, please. All right, so again, as with any sort of relationship in meeting, be calm and courteous, professional and polite. Always open the meetings by thanking the member or staffer for his or her time. As I said earlier, you'll most likely be in a meeting with a staff member. And remember, they're just as important, if not more, than a member of Congress. And often, if you're really trying to get something done, I think that's the best way to do it. Try not to interrupt them when they're talking, and more than anything, be flexible. This particularly comes up, I think, when meetings are in person and things happen, like you have to do a meeting while you're walking. But for instance, if someone puts you on hold because they have to take a call from their boss or something like that, again, I wouldn't be concerned. If someone's abrupt or rushed, don't take it personally. The Hill is really subject to a lot of last minute changes. Bills come up at the, issues come up at the last minute. Try very hard not to argue. I think this is important. Even if you don't agree, if something is, you don't agree, it's just best to not get into that sort of situation. Don't debate. And again, I told you I'd raise this over and over. Really, don't talk about politics. Don't talk about contributions. It's not remotely relevant to what we're trying to say. But I think you're going to have a great experience, and it will be interactive and fun. And it's relatively uncommon that you're going to have a situation where you get into a disagreement, or argue. Next slide, please. All right, so talking a little bit about meeting structure, I've talked around this, but I'm going to be very specifically explain what a meeting might look like. You go in and introduce yourself or your group, you say your name, you say where you're from, and you talk about your experience with Alzheimer's. These personal stories, the personal anecdotes, can be the most important part of what you bring to a meeting, and sometimes what a member, and especially well, especially a member of Congress will remember, staff too, but I think the members themselves can really be affected by that. Sometimes at this point or at another point, you can ask if one of the individuals has had experience. You don't have to, but if you feel that you need that to develop the connection, asking about their experience with Alzheimer's can help. You're then going to hand off, if there's more than one of you, or just one of you, state the items you're going to discuss in the meeting. And as I said, we're going to, at the close of our presentation, talk about 2 specific issues that we'd like you to raise in your meetings. You're going to introduce them and then sort of create a specific education and opportunities for the members to support something. And at the meeting's conclusion, thank them and remind them of anything you've asked them to do or talked about taking steps on. Try to stay on message. Don't use kind of jargon or very specific technical language, or assume that knowledge will be in that way, or that even assume that your staffer is too familiar with an issue, or maybe some of the subcomponents of what you're educating them on. As I said earlier, every staffer has a different experience, and some may be more familiar with these things than others. Very important point. If you're asked a question you don't know the answer to, do not feel compelled to answer it. Don't make up an answer, which I think some folks feel inclined to do. Offer to get an answer and follow up, or better yet, have the staff at Us Against Alzheimer's follow up. That's what we're here for. And please reach out to us and let us know whether you've had a good meeting or not, but specifically if you're asked something. So I think it's really important for credibility that we have that kind of follow-up. And as I said earlier, use your real life personal stories. Try to tie your experience as much as possible to the district or state. As I said earlier, that cements your constituent relationship. So if you can say, I received care in this area, or I live here, etc., that really helps. And again, as needed, just keep going back to your main points. Next slide. All right, again, you close the meeting, thanking the member for their time. If you haven't already in setting up the meeting, and even if you want to reinforce it, make sure they have all your contact info, make sure they have your email and the best phone number to reach you. And then make sure, if possible, to get their contact information. It may be that you have their email from setting up the meeting. If they offer their cell phone or ask for it, that's great. That's how we've been doing business. It's not something that's necessarily publicly available, so it's great if possible to get that information, but not required. And reference any kind of leave behind materials that in this case you've provided by email. If they don't have access, don't remember receiving them, offer to send them again. And one point I always want to make is have a good time, have fun. A lot of times when I'm talking to folks about these meetings, they're nervous. I always say, don't be. As I said earlier, they want to hear from you, and folks
also be available below the player. If you're having trouble downloading it, email summit@usagainStalzheimer's.org for a copy. The toolkit provides a lot of information on the different mediums of advocacy available to you. It shows you best practices for phone calls, video conferences, and social media, but it also contains links to help you identify your members of Congress and the appropriate staff members to contact. We also provide some scripts that you can plug and play personal stories to and send pretty quickly to the relevant contacts that you need to reach out to advocate for things like Change Act or paid family leave. It should provide you everything that you need to be an effective constituent advocate. I'd like to turn it over now to Stephanie Monroe, who co-leads Us Against Alzheimer's Health Equity and Access to Work issues. Stephanie?
Hi, thanks, Brian. So back in 1993, Congress passed the Family Medical Leave Act, providing individuals who worked for large companies with more than 500 employees access to up to 12 weeks of job-protected unpaid leave for serious illness, to care for their loved one who had a serious illness, or to take care of a child following the birth or adoption. Well, 27 years later, nothing has changed in terms of the United States being the remaining country without a national policy that offers leave with pay. One thing that has changed, however, is that we now have over 16 million unpaid caregivers who are facing the predicament of having to choose between work and caring for loved ones. The United States does remain the only industrialized country without a national policy supporting paid leave. It's a top priority of Us Against Alzheimer's to respond to those 16 million caregivers by supporting legislation that would broaden our national unpaid leave policy and convert it into one that actually is meaningful for caregivers. A recent poll that Us Against Alzheimer's conducted showed that nearly 2/3 of dementia caregivers think that Congress should make paid family and medical leave a priority. This is a priority for us during COVID, and it's a priority for us in terms of a long-term strategy. In order to support a paid leave strategy that covers the spectrum of caregiving from children and adults, we need a policy that is realistic and that is meaningful to people who are dealing with loved ones, especially those who have chronic conditions like Alzheimer's. We need to make sure that people who are included in this relief and the relief packages that Congress is currently considering provide relief for at-home caregivers as well as those who are providing care for young children. We need to make sure that those policies contain meaningful income replacement benefits and job protections extended to employers of both large and small in terms of the number of employees that they maintain. We need to make sure that it contains workplace policies that allow caregivers the flexibility to accompany their loved ones to medical visits, including clinical research visits. And we need to ensure that the coverage is extended to extended family members, such as grandchildren, aunts, uncles, cousins, and domestic partners, who in reality in 2020 are those who may be called upon to provide and receive care. Of those 16 million caregivers, we know that increasingly this is a responsibility that is falling on the shoulders of today's millennials. Over 10 million millennials surveyed say that they are providing some portion of caregiving to their loved ones. There are individuals who are stepping out of the workforce in their 50s in order to take care of a loved one and receive some method of compensation. And so Us Against Alzheimer's stands with caregivers and is working with Congress to ensure that our national paid leave policy includes caregivers and those who have serious chronic conditions like Alzheimer's. We hope you'll join with us and include this messaging as part of your brain health advocacy. And now I'd like to turn to Niles, who will talk to you about what we're doing in terms of brain health and prevention strategies.
Thank you very much, Stephanie. We'd now like to give you a brief overview of the CHANGE Act, because CHANGE is really one of our top early detection strategies. Put simply, the CHANGE Act would require physicians to use a cognitive assessment test or tool identified by the National Institute on Aging to detect cognitive impairment during the Medicare annual wellness visit and the initial preventive exam. Now, I know that's a mouthful, so I'll unpack the key points of that momentarily. The CHANGE Act is S1126 in the Senate and HR 2283 in the House. It's useful for you to know those two bill numbers because you will probably be asked. So I'll just say them again. It's S1126 and HR 2283. Now, I mentioned two appointments that Medicare recipients are eligible for. The annual wellness visit and the initial preventive exam were created by the Affordable Care Act. These appointments were designed to address health risks and encourage preventive care in older adults. The law creating the annual wellness visit requires the doctor who is doing the exam to check for certain health issues in order to bill Medicare for the appointment. One of the health checks listed in the exam requirement is detection of any cognitive impairment. So we all think it's great, of course, that the annual wellness visit requires detection of any cognitive impairment. As we heard yesterday, early detection is so very important. The problem is that the Centers for Medicare and Medicaid Services, called CMS, that is the federal agency that regulates Medicare, instructs physicians to detect cognitive impairment by what they call direct observation. And direct observation is just exactly what it sounds like. The physician performs the exam, talks to the patient, maybe caregivers, and then decides based on what they see whether the patient has cognitive impairment. So why use an NIA-identified tool? Well, direct observation is very much the physician's own subjective opinion of whether their patient has cognitive impairment. And a person's observation of whether someone has Alzheimer's disease is wrong much of the time. Studies vary, but they found that about 50% of patients with dementia are unrecognized in the primary care setting. And as we know, emerging science points to the ability to slow the rate of cognitive decline by addressing risk factors. So there are things we can do even as we await a treatment. Early detection helps clinicians anticipate problems that patients may have in adhering to medical treatment plans. It allows for participation in clinical trials, and it provides a basis for advanced planning on the part of patients and their families. Now, it's important to note that these screening tools do not diagnose dementia per se, but the results tell providers whether further evaluation is indicated. So all of that is why we need to ask lawmakers to co-sponsor the CHANGE Act. The CHANGE Act currently has 47 co-sponsors in the House and 22 co-sponsors in the Senate. Now, those are solid numbers, but we need more. Having a lot of co-sponsors, even this late in the year, is crucial for at least three reasons. First, having a significant number of co-sponsors is necessary to move the bill through the legislative process. Second, even if the bill doesn't get passed this year, it lays the groundwork for next year, because lawmakers who co-sponsor now are much more likely to co-sponsor it again next year. And last, adding co-sponsors sends a strong message to the federal agency, to CMS, that members of Congress favor this early detection policy. We are working on a multi-pronged approach to advocating for use of an assessment tool by moving the bill through Congress. And we also work directly with CMS because they can do much of what we want through the regulatory rulemaking process. And CMS is more likely to do that if they see a significant number of representatives on Capitol Hill supporting that policy. So during your conversations on the Hill about this Change Act, that is the ask. Please co-sponsor the Change Act. It's not enough to talk to them about why the Change Act, why early detection is so important. We really need to make that specific ask. Now, almost all of the time, staff and members of Congress will not make that commitment during your initial conversation. Instead, they'll say they will look into it and then make a decision. That's perfectly fine. And it's really all we can ask. And that's why doing the kind of follow-up that Stu and Brian discussed is absolutely vital. After your initial conversation, you can go back and touch base with the office a couple of weeks later, ask if they've made a decision, try to answer any questions they have, etc. Now, we would love to hear from you as you have conversations with your congressional offices about how those meetings went, any questions they asked, etc. That gives us the opportunity to follow up on your visits. Please call on us if you need more information or if you have any questions. Now, we will have time for some Q&A shortly, so if you have a question, please let us know by submitting it in the chat box. Thank you very much for joining us today. We will now hear a short message from civil rights icon Dolores Huerta, who has spent her life advocating for social justice.
Alzheimer's is a devastating disease that affects not only individuals, families, and communities. And again, it is costing us so much financial resources to be able to deal with this terrible, terrible disease. The one thing that we do know, though, is that if all of us work together, that we can find a way to fight Alzheimer's. In my own family, my grandmother had Alzheimer's, one of my mother-in-laws had Alzheimer's, and they would often go out and walk all by themselves, and we'd have to go send everybody out there to see where they were at to try to find them, putting their lives in danger. And so we know that this is something that when a family is affected by Alzheimer's, that it really takes all of the emotional being out of these families. And so we know how devastating it can be. The one thing, though, we know that we are going to be able to find a cure for Alzheimer's, but we've got to do it all together. I think it actually affects women even more because women are often the caretakers of the families, and of course, and people of color. And we also need to give them information of the behavioral habits, the things that they might do to contribute to bring on this Alzheimer's disease. Well, I am so happy that we are partnering with the Latino Coalition Against Alzheimer's, working all together. And I'm so happy that we're having this great summit, Us Against Alzheimer's. And basically, that's what it's going to take. It's going to take all of us working together to be able to be sure that we can beat Alzheimer's. I know that we can do it. Sí se puede.
Hi, everyone. Thank you. We were going to take some time for questions, and I'd like to start with one that we got. I get a lot from advocates, and it's about how do we make our issues relate to COVID-19 right now. We talked during the presentation about the importance of weaving this in as much as we can. Can either of you give us some ideas on how to make that possible?
I'll chime in and then wait for others. I think it's important that you try to talk first about any experiences you might have had. For instance, if in fact you weren't able to have your usual care, which is quite possible, you weren't able to have individuals come in the home, and then you had more of a burden for in terms of your leave. That's something that ties in very directly to what Stephanie talked about. And it's a way to both make this about COVID and personalize the situation and then tie this in. I think you can relate it to the Change Act as well in a more diffuse way, talking about your, fact that you weren't able to go to the doctor potentially for a certain period of time. and how it's more important than ever that you have a, the proper and appropriate screen when you go. Others?
I agree with that. I think that's where you being able to talk from your personal experience is very important, because everyone on the Hill, as well as elsewhere, has really been flooded with news about statistics and so forth about the kind of toll that COVID is taking on the country. But what will really break through all of that fog is you sharing your own personal stories, telling how you or your loved ones have been personally situated as a result of COVID. So that's something that lawmakers and staff don't get just by reading the headlines, and it's always a terrific way to break through.
Stephanie, do you want to
Sure.
add in on that?
I think very specifically, Congress has been attentive to what they know. And with respect to paid leave, they've certainly been attentive to the needs of working families who have young children who aren't able to go to school or whose daycare centers have been shut down. We've been working to draw attention to the fact that millions of Americans who have come to rely on adult centers, adult caregivers coming in to provide supports for their family members with chronic conditions, that they too aren't able to work. And in some cases, people have had to be removed from other senior living options because those senior living options weren't as safe as they had been previous to COVID. But there's been a reluctance of Congress to recognize adult caregivers in these scenarios. We were able to achieve some pandemic relief in the CARES Act so that people who became unemployed and they were caregivers were able to get some relief, but that certainly was far less than what we hoped for and far less than what caregivers of young children were able to receive. And so raising those voices and letting them understand what's happening with adult caregivers will be really important. I can tell you personally, as a former Hill staffer of more than 25 years, I crafted legislation sometimes based on an anecdote that came in from my state, and would pursue what was happening with that individual and how I could convey the member of Congress, the senator that I was representing, to really pay attention to that, because that one voice that we heard was really representing hundreds of others that we were not hearing from. So your stories are absolutely imperative. It puts a face and a person on what might be a statistic and can be very influential. So sharing your stories is really very powerful.
Thanks. I think that actually segues into our next question pretty well. COVID-19 has been a time of unprecedented challenges, and one of our audience members would like to know what's been our biggest challenge as an advocate during this time. Sue, do you want to start with that?
Sure, and then I'll probably kick it off to Niles. I think, I'm going to almost do a 180 and say that where we haven't been coming in to talk about something that's very imminent immediately about COVID, it can be hard to get attention. And, you build up sort of energy around an issue, and this has been a very unprecedented time. So again, it's not getting deterred by that, continuing in the appropriate way to bring about our message and stay on point, but also hear what's going on and the kind of feedback we're given on how to do that.
Yeah, I agree with that. When we have reached out to people on Capitol Hill or even people in the administration, they've said, look, what you want to talk about is important. We're happy to listen, but we can't do it right now. Let's wait until COVID moves onto the back burner. And of course, that hasn't happened yet, and there's no indication it's going to happen anytime soon. So it's really been just to try to fight the fact that COVID is really taking all the oxygen out of the room for much of the year. As Sue said, we're starting to see that change a little bit now, which encourages us.
Stephanie, have you had any challenges that you want to share?
Oh boy, how long do you have? Well, I think I think one of the challenges is that, specifically, we thrive on creating this relationship. And of course, as everyone in America is socially distancing, the inability to connect in person, eye to eye, is a challenge. The virtual meetings are effective and we continue to do those, but I think we all are awaiting the time when we can actually see people in person, face to face, to have the kind of a connection that you may not be able to get through virtual contact.
Yeah, I mean, it's, as an advocate, I can say it's been challenging, but also those challenges lead to some new opportunities, which has been really exciting. Specifically on the Change Act, though, Niles, and I'll throw this one to you. Can you give us some examples of NIA identified assessment tools?
There are 3 of them listed on the NIA website, and I'd be happy to share that with anyone who wants to know after the fact. And it's really important to follow the language that the NIA uses very carefully. The NIA says that it has identified several tests. They make it very clear that they do not validate any of them. So they essentially say, here are 3 tests, and these are the kinds of things that clinicians can use. The NIA also says that they are doing more study and more research of identified tools, and they hope to make more available at some point in the future.
Great. And on another one of our issues of paid family leave, Stephanie, I'll ask you this. One of our members wrote in that a little concern for retired couples where the caregiver needs a break or getaway, needs some kind of financial assistance. What options do they have? What legislation might they be able to benefit from for a retired person who needs help?
So that's a great question. And I think one of the challenges, frankly, that COVID has presented is isolation. That's certainly impacting caregivers who are shut in, and especially those who are in senior care facilities, where the reason that they wanted to go there was because of the socialization, was because of being able to get together with communal meals and take field trips and play bingo or mahjong with people. What we see now throughout the country to protect individuals is that they are pretty much locked in their rooms, 600 square feet, potentially with another individual who has Alzheimer's and other caregiver who might be the same in their age and 80s, without having that access to the helps that they need to bring inside, but also access to the family members who could provide support for them. So it is very challenging. Respite is important. I believe, and I'd need to check, but I believe the Older Americans Act does provide some small relief that's available to states through the area agencies on aging for respite. There are private organizations like Hilarity for Charity that raise money to provide grants to deserving individuals, of which everyone is one, to be able to help them get some respite, whether it's get one person to come in a week, to give the caregiver a couple hours to go, frankly, to the grocery store by themselves or get their nails done. There certainly is not enough, and that's an issue that in terms of long-term, we absolutely need to figure out what does that look like. COVID's made it very challenging because to keep people safe, isolation has become a real priority. But it's certainly coming out of COVID, I think will be worthy of some further data collection and information on what really has happened to individuals who are thankfully and safely living, but whose Alzheimer's or other dementias may have been adversely impacted because of isolation. And then getting that data will be helpful, I think, in deciding what kinds of additional public policy is needed for individuals who are retired or in those kinds of positions.
Thank you. That's really helpful information to have. We're going to wrap up here shortly, but I wanted to quickly go back to Sue on what someone should do if emails and follow-ups, they're really aren't working, they're trying hard, they're not really breaking through the logjam. Can you provide some advice to us on how to get through that?
Sure. Well, first of all, I would not be concerned if this happens and feel that it's a reflection on your efforts in any way. As I said earlier, the volume of email, and we've all been staffers, is it's immense, and it's larger now than ever because the switchboards aren't open in the offices. So I would keep at it with appropriate intervals between times. I would change your subject line. Note that you have a specific date you're requesting. Somehow try to make it more time sensitive. But I think that if you typically continue and you're not concerned with having to do something a second or a third time, that's an appropriate way to keep doing it.
Thanks. And we just got one last question in on the chat box that I'd like to kind of let everyone take a chance to speak to. He says, any particular advice for advocates of color? They've advocated in DC, but felt like they're taken less seriously, especially when they speak with white, non-Latino, male conservative politicians. Any advice for those kinds of advocates?
Well, as a person who fits in that category very neatly, anytime that you're talking with a member of Congress or a senator, I think it feels threatening. I would say, many of these members don't necessarily relate to where we are as a community, not just as an African American or Latino community, but they're not walking in our day-to-day shoes. Many of them, and I don't like saying in general, but many of them have not ever held a job outside of politics. So we should feel very empowered to help inform them of what the real deal is in their communities. And if you don't speak up, who's going to speak up on your behalf? So I think the idea that our messaging is really important, it's really unique, our vote counts, it matters, and sort of shame on the member who wants to disregard the influence and the impact that one of their constituents is trying to share with them. We have to hold them accountable. We need to make sure that our stories are told, and we can't wait for others to tell our stories.
Well, thank you very much, Stephanie. And I think that's about all the time that we have for this Q&A. Again, thank you everyone for tuning in. And I'll turn it back over to Niles.
Thanks very much, everyone. If you had a question that we didn't get to answer, and I know one person asked the question about the NIA tools, I would be happy to get that to you. I'll just give my email address. It is ngodes@usagainstAlzheimer's.org. If you have any questions or would like any additional follow-up information, please feel free to let me know. And thanks very much, everyone, for joining us today.
And next up at the 2020 National Alzheimer's Summit, we have a mindfulness break brought to you by our friends at the Center for Brain Health at the University of Texas at Dallas.
Hi, welcome to the Brain Health Booster video series, where we're sharing with you science-backed tips and tools to help you strengthen your brain health. I'm Jennifer Zients. I'm head of clinical services at the Brain Performance Institute. Disruptive events, disruptive times, disruptive situations, they require innovative thinking. Why? Think about the last time you've had a pretty big disruption of your life. Maybe it was because of a mistake you made or somebody else made. Every time we make errors, we typically find ourselves finger pointing, ruminating. What our brain's doing in those situations is it's wiring to that negativity. We need to unwire that and start to wire to possibility thinking, to the positives. And how do you do that? It's about reframing. Thinking about errors, thinking about mistakes, situations, pretty significant disruptions. How do we reframe and find fresh life? Where are the challenges and the opportunities that we can grab? How do we see the positives that lie within those interruptions? That's one of the ways that you can strengthen your innovative thinking. It builds stronger frontal networks and it leads to more neural efficiency. Give it a shot. Hi, welcome to the Brain Health Boost video series, where we're sharing with you science-based tips and tools to help you strengthen your brain health. I'm Jennifer Zients, Head of Clinical Services at the Brain Performance Institute. How did you express your gratitude the last time someone did something nice for you? Did you default to your standard written thank you note, maybe the gift basket you always send, or even a verbal thank you? The next time someone does something nice for you, I want you to challenge your status quo. Evaluate what you always do and try to do something different. Why? This is requiring creativity, innovative thinking, flexibility. Coming up with novel ways of expressing gratitude helps your brain at a neural level. It strengthens frontal networks. It also gives you norepinephrine doses, which is our brain's wonder drug. But it's also important for our overall well-being and social cognition, which is our ability to have relationships with others. So the next time somebody does something nice for you, challenging your status quo can have a much bigger effect than you think.
The population of people living with Alzheimer's and related dementias in the U.S. is changing and becoming more diverse. But our nation's healthcare and research systems often fail communities of color, poor people, and women. When it comes to clinical trial diversity and sex-based research, America's research system falls woefully short of full inclusion. Our research doesn't include enough people from diverse racial, ethnic, and socioeconomic backgrounds, so we can't ensure breakthroughs will work for all Americans. Compounding this national tragedy is that Alzheimer's and related dementias have a disproportionate effect on communities of color and women. Despite this increased risk, our healthcare system limits equal access to promising treatments, health services, and interventions essential to stopping Alzheimer's and addressing key risk factors. Black Americans and Latinos are less likely to receive a timely diagnosis or participate in Alzheimer's research. Black Americans and Latinos in the counties with the highest prevalence of Alzheimer's also experience greater levels of social inequity. And the high costs of Alzheimer's care and treatment are limiting economic opportunities for Black and Latino families. The trends are clear and alarming. By 2030, nearly 40% of all Americans living with Alzheimer's will be African American or Latino, unless something is done. Our nation must recognize the role that systemic racism has played in creating this grim reality for families confronting Alzheimer's if we are to address these health disparities at their root. Without action, under-resourced communities will remain at a disadvantage when it comes to advances in brain health. As a result, societal inequities will continue to grow. Our nation's best-in-class healthcare system and research system will continue to shortchange millions of Black and brown families, and they will continue to be left behind. This cannot stand. Our government leaders, the nation's healthcare system, and healthcare industry partners must set and be held to goals for advancing health equity and research recruitment, access to healthcare services, and improvements in quality care. If these steps are taken, our nation can make significant progress in delivering on the promise of brain health for all communities. What kind of national goals can we set to help address systemic racism in access to Alzheimer's health services and research?
Good morning, good afternoon, good evening. Welcome to another wonderful session in store at the National Alzheimer's Summit in 2020. We appreciate all of you joining us here virtually this year. This session is entitled No Access, No Justice, Addressing Systemic Racism in Alzheimer's Research and Health Services. I'm going to be your moderator. My name is Jonathan Jackson. I am the Executive Director of the Community Access Recruitment and Engagement Research Center at Massachusetts General Hospital and Harvard Medical School. We've got a wonderful set of panelists with us here today. We've got Ms. Quita Highsmith, the Chief Diversity Officer at Genentech. We've got Mr. Brian Van Buren, who is a patient advocate living with Alzheimer's disease. We've got Dr. Fabian Sandoval, who is the CEO and Research Director of the Emerson Clinical Research Institute. And we've got Rear Admiral Risharda Araujo, who is the Associate Commissioner for Minority Health and the Director of the Office of Minority Health and Health Equity at the U.S. Food and Drug Administration. So thank you so much to all of our panelists. But before we start this conversation, we have a quick and special message from Civil Rights Act leader and legend, Reverend Al Sharpton. Reverend Sharpton had his first-hand experience in dealing with our nation's Alzheimer's challenge and has some words of advice for us as we center racial and social justice in our discussion today. Reverend Sharpton.
Well, my mother raised my sister and I in Brooklyn, New York by herself. I was a child of a single parent. And once I was fully grown and on my journey, she moved back south. She was from Alabama. And slowly she began to develop Alzheimer's as well as dementia. And she had 2 children older than us down in Alabama. And they would call me and say, she's, starting to forget things. And she would leave her house and didn't know how to get back. So finally, I would go down and see her. Finally, we decided to put her in a nursing home. And she didn't even know who I was at one point when I went to visit her. And I think that one of the reasons I'm so committed to this group is that there's nothing that can prepare you for going to see your mother who in my case was my mother and father, and they don't even know who you are. We need to take the health conditions in Black America more seriously. We need to be more engaged. When we see that Blacks are twice more likely to face Alzheimer's and dementia, 1 in 3 seniors in this country die from it. This is something that is, as in my opinion, needing a sense of urgency as anything we fight in civil rights. And the race gap in terms of healthcare is something that we should not tolerate or act like it's some back page problem. It's a real problem, and we need to deal with it in an aggressive manner. There must be an intentional program strategy that includes everybody, including the poorest and the Black community. Many of our communities don't even have healthcare facilities directly in the community. So you've got to be able to develop strategies that will bring them where the care can be available to them. Healthcare is a civil right, and we need to talk about the disparities there like we talk about the disparities in criminal justice and in business and in employment. We need to first use our platforms to get the message out. Secondly, we need to constantly be on the legislators' backs, because they're the ones that regulate and deal with all of this, to say that part of what they need to know as they deal with healthcare companies and all is what is their plan for diversity? What is their plan to work with those that are in the industry that are servicing communities that have been institutionally neglected?
All right, thank you so much for those magical words, Reverend Sharpton. And welcome back everyone to our session where we're going to be talking about no access, no justice. Before we jump into our questions, I wanted our panelists to briefly introduce themselves, and I'm going to call on them to let you know what's important to know about them before we jump into this much needed and long overdue conversation. We're going to start with Ms. Quita Highsmith, the Chief Diversity Officer at Genentech. Quita.
Thanks, Jonathan. I'm Quita Highsmith, Vice President, Chief Diversity Officer at Genentech. And for those that don't know, Genentech is a biotech organization that is considered the founder of the biotech industry. And, you know, I think one of the things that I am very proud about the organization is we've been on this journey thinking about advancing inclusive research for a number of years. And when we think about including patients of color in our research, that is very important to us at the forefront of what we do. And when we worked on products for COVID, I'm happy and proud to say that in one of our studies, 85% of the patients in the clinical research were people of color from the Navajo Nation, African American, Black. We went also to Kenya, South Africa, and Peru. So this is an important conversation because we can do this. We can include communities of color in research.
Thank you so much, Quita. And that number, 85%, that is astonishing. So I can't wait to talk with you a little bit more about how you got to that number when some of us are struggling for a tenth of that much. Next, we're going to go to Dr. Fabian Sandoval, the CEO and Research Director of the Emerson Clinical Research Institute. Dr. Sandoval.
Hi, thank you for allowing me to be part of this outstanding panel. I'm honored. So Emerson Clinical Research Institute, we're based out of Washington, D.C., but we also serve Northern Virginia and Maryland. We have patients that come to us from as far as Baltimore, almost an hour away from where we are, because we really provide the service of ensuring that our diverse patients are participating in these studies. We have a huge outreach program. We also, through our foundation, we work with the consulates of Mexico, Guatemala, and El Salvador to educate the communities there and let them know the value and importance of participating in clinical trials. And it's been very successful because of that. I say 99.9% of our patients are from underserved patient populations. Our highest numbers are Hispanics, followed by African Americans, and then some Asian and Caucasians. And then through our TV show, Tu Salud, Tu Familia, which airs every Saturday morning at 11:30 a.m. on Telemundo, through a grant that was offered to us through Genentech, we've been able to continue this outreach, and we're able, actually our Emmy award-winning show that talks about healthcare awareness and clinical trials. So this has been a very big push as far as educating the community is concerned. So having these this outreach effort and working closely with the patients, we have developed that true level of trust, and that's where Emerson Clinical Research now stands.
That is phenomenal to hear, Dr. Sandoval. Those numbers, I thought 85% was impressive, but you raised the bar with 99%, and now we've got Emmys being thrown around here. I mean, we're going to have quite a conversation. We're really leaving everyone else behind. So thank you so much for being here, Dr. Sandoval. Next, we've got Rear Admiral Risharda Arrojo with the FDA. Rear Admiral, would you like to introduce yourself?
Hi, good afternoon, Jonathan. It is a pleasure to be here with everyone today. I'm Rear Admiral Risharda Arrojo. I serve as the Associate Commissioner for Minority Health and Director of the FDA's Office of Minority Health and Health Equity. And our office works to protect and promote the health of racial and ethnic minority, underrepresented, underserved populations by focusing our work on research and outreach and communication that works towards addressing health disparities. And as you can imagine, a key priority area for us is working to advance racial and ethnic minority participation in clinical trials. So very excited to be here and to have this very important conversation.
Well, thank you so much. We recognize that there's only so much that we can do locally, and we certainly need to be strong partners with your office and the FDA more broadly in order to ensure that we have the infrastructure that we need to guarantee diverse and inclusive research, especially here in the dementia and Alzheimer's space. And then our final panelist that I'm going to introduce to you is Mr. Brian Van Buren, who is one of our wonderful patient advocates who is living with the diagnosis of Alzheimer's disease. Mr. Van Buren, would you like to introduce yourself?
Sure. My name is Brian Van Buren. I'm a Black gay man living in Charlotte, North Carolina. I am married to a Brazilian, and unfortunately, because of the virus, I have not seen him since March. I was diagnosed in 2015 with early onset Alzheimer's, and I started doing research and was appalled to see that Blacks were diagnosed twice the general population. I serve in a lot of committees, I've spoken at a lot of conventions, and I've yet to meet a single Black person with Alzheimer's. It wasn't until I met Bee Smith and her husband at a book signing, and she was the first person who I was able to meet, connect, and we became very good friends. And I learned a lot just by reading her book about what was the journey to be a Black man with the disease.
All right, thank you so much, Mr. Van Buren, and really appreciate that you're here and that you're willing to be so vulnerable and open and honest about the shortcomings of our research infrastructure, especially for individuals who hail from diverse racial and ethnic backgrounds. And I think that really starts us off with the first question, and this is for all four of our panelists. We talk about inclusive research. I think we all recognize, everybody who's watching this recognizes that it's an important thing to do. But why is it important from a scientific perspective? Why is it important from a drug development perspective? Why is it important from an access perspective? Let's move beyond the argument around this being a matter of social justice. What are some scientific and some business reasons to be diverse and inclusive with our Alzheimer's research?
I'll start. I think one of the things that is very important is as we think about where technology is going, and technology is using genetics and genomic information more and more every day. And when we think about the data that is collected in that technology, looking at genomics, the majority, 90% of the GWAS data, which is the genome-wide sequence data, is 90% of that data is white. And it's actually growing more white. In 2016, when we first started to look at some of this, it was 81% of the GWAS data was of European ancestry. And now fast forward to 2020, in a very short period of time, it's jumped up to 90. And here's why it matters. Because most companies, pharma companies, are using artificial intelligence algorithms to make treatment decisions based on the data that they have. And if the data is not diverse, then what's going to happen is the algorithm is going to be built for a white male. right? And so me as a Black female, if my data is not included in the system, then we're not going to be represented, and we're going to be leaving a lot of communities behind. So it is critically important that we have more communities of color participating in the research.
Yeah.
That's
And,
so.
you know,
Go ahead, ma'am.
the other thing I'll just add to what Quita just mentioned, I think that when you think about a clinical trial, just the basics of a clinical trial, we know that from an FDA perspective, it provides us a crucial base of evidence so we can evaluate whether a medical product is safe and effective. And so ultimately, as Quita just described, we want the diversity of the population that are ultimately going to use those products to be included in those trials. We know that persons of different ages, races, and ethnicities can react differently to certain medical products. And we want to make sure that we have enrollment of those trials reflecting the diversity of those that are using the products so that that data can be appropriately analyzed and that more meaningful information can be communicated to the public and in the product labeling.
Nothing else to say. Exactly. These two women are hitting exactly what I would say. We don't know. We need to know the side effects. That's what I'm looking for. So at boots on the ground here in the lab, I'm looking for those side effects. What are those common side effects that our communities have that other communities may not have? And that's what's important. And that's what I tell my patients. We need to make sure it's going to work with your community, with our patients, because when your kids get older, they're going to need this. But if you're not in this study now, we're not going to know if the same side effects are the same for the different populations. So yeah, that's it.
Yeah, and Mr. Van Buren, is there anything that you'd like to add on this particular matter? You know, from your perspective, why is it important to have diversity in research trials?
Sure. I was going to say that it's extremely important Afro-Americans get involved in clinical studies. Unfortunately for myself, having comorbidity issues such as diabetes and hypertension, I've been denied every study I've tried to get involved with. Also, the fact that I don't have a 24-hour care partner has also excluded me. So those ramifications need to be changed. I am a strong advocate, however, even though my grandfather was part of the Tuskegee study and died from syphilis, I tell people, because there's still a lot of suspicion within the Black community about the medical field, that it did happen. It was a bad thing to happen, but we need to move on from it.
All right, so I want to open this up to the rest of the panelists. You know, all five of us seem to agree that this is important, that it's important for lots of reasons: social justice, science, the quality of our big data sets. We recognize that this is an area of focus and importance, even from the FDA. So the question is, why aren't we doing it? What's stopping us from having that diversity? Is it all just a matter of Tuskegee and inclusion and exclusion criteria for studies? Or are there other factors that are driving this lack of inclusion?
So I think it's a couple of things. I think what Mr. Van Buren said is important for us to hear. Like, Tuskegee is in the minds of people. And we've just fielded some research with 2,000 patients earlier this summer. And patients, and we looked at 1,000 of the general population, 300 LGBTQ, 300 low socioeconomic status, meaning they made less than 35,000, 300 Hispanics, 300 Blacks. And what we found was that the patients don't actually believe that they're going to be treated fairly. The medically disenfranchised, the LGBTQ, the Black, the Hispanic, and the low socioeconomic, they actually think that the system is flawed against them and actively don't trust that the healthcare providers are going to have their best interests at heart. So they're not going to be interested in vaccination trials. They don't trust the testing. And so one of the things that we have to do is we have to reach out to the community to be able to explain what the rationale is so that they are wanting to participate and to be involved, which is one of the reasons why we've worked so closely with Fabian and his Telemundo show, because we've got to get the message out and it's got to be trusted partners in the community. like Fabian, Dr. Sandoval can talk on his show and give the rationale of why Hispanic patients should participate as a trusted source. We've used many of the materials that Rear Admiral Arrojo from the FDA minority, they provided us that speaks to communities of color. Like, we've got to stop talking at a high level, and we got to get into the barbershop and the beauty salon, and we got to get to the church, because that's where the people are who need to hear the message, and then they will be willing to participate.
Yeah, it's a constant education, just like we're always, we always have to teach people how to read, right? We always have to keep teaching math. That's something that has to happen from the beginning. We have to continue to preach the value of this. This can't be just for 1 or 2 years and it's it, because then knowledge is going to fade away and we're going to be back to square one. It's a continuous cycle that we have to continue this process, and that's what we're doing. So that's probably the biggest challenge, and ensuring that trust. I mean, we say it over and over again, but now we're actually living it, and we have the proof that it works.
Rear Admiral, I wanted to kind of piggyback off of these thoughts. So we have clear examples, from QUIDA, from Dr. Sandoval, of what works. We understand that it is possible to have, a lot of underrepresented racial and ethnic minorities participate in research studies. According to the FDA's 2019 clinical trial snapshots, the FDA approved 9 neurologic drugs last year. And according to those snapshots, 77% of the participants for these trials were white. So, in light of some of these counterexamples, what tools does the FDA have at its disposal to really encourage the inclusion of people of color across research studies?
Jonathan, I think that's a really good question. And, the FDA, we have continued to work to increase the participation of diverse populations in clinical trials, from hosting public meetings, developing tools, as well as issuing guidance documents that all work towards supporting diverse participation. And of course, as I mentioned earlier, a key priority for the Office of Minority Health and Health Equity is also working to advance racial and ethnic minority participation in clinical trials. And so some of the tools that we have, I'll start with one that you just mentioned. So for example, the Center for Drug Evaluation and Research at FDA developed drug trial snapshots. Drug trial snapshots provide consumers with information about who participated in clinical trials that supported FDA approval of new drugs. And what's great is that in addition to the information for that particular new drug, they also put out yearly summary reports. And that is basically aggregate data for that particular year based off the products that were approved. And for the example that you mentioned for neurology in 2019, there were a total of 10,390 patients that participated in trials that led to the approvals of 6 new drugs. So how that breaks down is that overall there was about 75% of all participants were women, 77% were white, 10% were Asian, 11% were Black or African American, and 13% were Hispanic. And what we also have within that particular data is the indications. So for example, 4 out of 6 of the products that were approved have indications for diseases and conditions that have a higher prevalence rates within whites. So I think what we have to remember when we're looking at snapshot data is that it's a snapshot of that data within that period of time, and that we are constantly accruing additional data, and even post-approval, we are getting additional data on those particular products. And we also have to remember that when we're thinking about Alzheimer's drugs and working towards advancing, and we have to continue to work toward advancing racial and ethnic minority participation in those trials, as well as broadly across research overall. And some of the ways that we're able to do that, I definitely want to highlight, and I'll kind of speak to this quickly, but I definitely want to highlight that some of the other ways that we're able to work to do that is through issuing guidance documents. We have our 2016 collection of race and ethnicity data and clinical trials guidance document. This guidance highlights FDA's expectations that sponsors enroll participants who reflect demographics for clinically relevant populations with regards to age, gender, race, and ethnicity. We also have the 2017 evaluation and reporting of age, race, and ethnicity-specific data in medical device clinical studies. And then most recently, we have a draft guidance that was issued in June 2019. And I think this one's really important to mention because it focuses on enhancing the diversity of clinical trial populations eligibility criteria, enrollment practices, and trial designs. And we just talked about eligibility criteria. And this specific guidance focuses on broadening eligibility criteria, avoiding unnecessary exclusions for clinical trials, and improving trial recruitment so that participants enrolled in trials better reflect the populations most likely to use that drug if the drug is approved, while of course maintaining safety and effectiveness standards. The other area that, speaking to guidance documents, of course, during the COVID-19 pandemic, we are continuously working to raise awareness around the importance of minority participation in clinical trials. This is highlighted in two guidances that are specific to COVID-19. One is the development and licensure of vaccines to prevent COVID-19, and that guidance specifically states that FDA strongly encourages the enrollment of populations most affected by COVID-19, specifically racial and ethnic minorities. And another guidance that focuses on COVID-19 and developing drugs and biological products for treatment or prevention also states that racial and ethnic minority persons should be represented in clinical trials, and it goes on to talk about how sponsors should ensure that clinical trial sites include geographic locations with a higher concentration of racial and ethnic minorities to recruit a diverse study population. But in addition to guidance, one of the areas that I really think is very important is education. We need to make sure that our communities have information so that they can make informed decisions. And the Office of Minority Health and Health Equity, we developed an ongoing campaign that works to provide positive reinforcements through education and multimedia to help address some of the barriers preventing racial and ethnic minorities from participating in clinical trials through a variety of different culturally and linguistically competent strategies, tools, and resources. Quita mentioned some of these earlier. We've developed fact sheets, brochures, and other educational materials in multiple languages that highlight the importance of diverse participation in clinical trials. We have videos and public service announcements. We engage in social media outreach. We want to make sure that we're able to reach the diverse communities that we serve where they are. So we try to have a broad range of materials and outreach and engaging different communities, engaging health professionals, all working to provide that education about why diversity in clinical trials is important. And lastly, I do want to highlight that the other area, when we look at the barriers to participation in clinical trials, we see that those barriers cross multiple sectors. So collaborations and partnerships and engaging and working together so that we can share best practices, that's an area for us that's very important. And of course, collectively, all of these efforts are areas where we're working to continue to advance diverse participation in clinical trials and, of course, ultimately diversity in the data that is submitted to FDA.
Well, thank you for such a wonderfully comprehensive response. So it sounds like there's very clear guidance. It sounds like there are resources. It sounds like there's a collection of best practices. I know this question is going to come up later, and so maybe we can head it off now. Rear Admiral, is there any plans or is there any language within current guidance around enforcement of around mandating or maybe penalties or perhaps incentives to really strongly encourage diverse and inclusive research, especially here for neurologic diseases, particularly focused on dementia? Is that something that you can comment on, or maybe give us a hint about? Just making sure that these policies and these resources are taken seriously, so that the examples that are that were substantiated by Quita and by Fabian, that they are less and less the exception and more kind of the norm and the reality.
So, we work within our regulatory authorities, and one of those ways where we can continue to advance and work towards and really highlighting our current thinking around it is through guidance documents. I highlighted a number of the guidance documents that we have where we really highlight how we strongly encourage and work towards advancing diverse participation in clinical trials. The other thing that happens that, just to highlight, and I'm sure Quita may speak to this as well, is that in addition to the guidance documents we have, we know that within our review divisions, they are talking with sponsors, they are working with sponsors so that we can continue to advance representation, appropriate representation in clinical trials. The other thing that I think is important to mention, and I can highlight a docket that the Office of Minority Health and Health Equity opened this year. We opened a docket so that we could actually get public input and comment on the strategic priorities for our office. And that offered an opportunity for us to get broad public feedback on where our stakeholders feel we need to do more. So I think that's another area where we're able to seek that public input feedback from across all of our stakeholders on the issues that impact the populations that we serve.
Let me just piggyback Sade's comments. First of all, two things. One, transparency. So when the FDA started to do the FDA snapshot so companies could really look at it, it was like, you know what, it's a wake-up call, right? Because it was being, for every new drug application, they were putting on their website for the whole world to see what was going on. So like conversations like this bring that to the forefront, right? So we have to be transparent to be really talking about and putting the issue on the table. The other thing is you budget what you value, right? So if it's valuable to you to include diverse patient populations, you will do that. And then when we've been working to move the needle for a number of years, but it takes time. And so luckily, because we've been working and we've had stakeholders like Fabian go through our inclusion exclusion criteria and tell us where the bias was built in, right? In the process, so that we have real world patients, not fairy tale patients, like Mr. Van Buren was talking about. He has Alzheimer's, but he has some other comorbidities, so now he got excluded, right? We got to stop with the fairy tale patient and have a real world patient that is included into the clinical trials. And one of the things that we saw with this study we did on COVID is we went to where the patients are. I mean, it's okay to go to the academic centers, but people are going to the community hospital. They're driving by that facility, and that's the facility they trust, the one that they see, you know, that they drive by. And then, you know, for us, oftentimes in our industry, the pharmaceutical industry, you know, doing a partnership with a new facility is a little bit taboo because it's like, oh, well, it's going to slow us down. We're not going to be able to finish enrollment. That is a myth, and we proved that with this study. It does take a little bit more time to work with a new facility, but what we learned on the back end, it might take us a little bit of extra time on the front end to get that facility up and running. But if you go to where the patients are, you actually enroll faster. And we looked at streamlining our process and really thinking about what is the fewest eligibility criteria that are really needed. And I think COVID is going to help us think about better remote monitoring and other things that we wouldn't have done so quickly had we not been in this time frame. So I definitely think there are things that can be done, but it starts with transparency and the proper budget.
You know, also, don't forget about the sites. So the sites also need to be pushed and selected properly. A lot of sites, right? I get paid $10 if I, you know, no matter what color my patients are, I still get paid the same. So unless it's an inherent value to me as the, you know, at our site, which is our only drive-in mission, just because the reason why it's a drive-in mission for me is because I'm Hispanic myself, right? There is a benefit for me to make sure that I get more Hispanics in studies because one day I might need that drug myself, right? So what is the incentive for sites to do it? There isn't, right? It doesn't matter, right? So sponsors are now picking sites to say, all right, can you enroll diverse patients, right? And if they can and they can prove it, then those sites will bubble to the top and they will get selected to be those sites to conduct those studies. That's something because the sponsor companies may have all these great ideas to actually make it happen, but if they pick a site who they're just going to enroll whomever and not have a little bit of that need to include diverse patients, now we're back to square one. So we need to make sure we have that proper fit between the sponsors and the sites to get the right kind of patients in. So sites need to also get on this bandwagon and say, yes, we are going to do this because we see the importance of doing this, because there is no stick like you were asking before, Jonathan, right? The FDA is not going to say you have to do it. And the sponsor companies may say, you really need to kind of sort of do it. So the sites need to say, okay, we're going to do it. That's the important part. So we all need to kind of get nudged a little bit to see that we have to do it. So that's my part. And I see Mr. Van Buren had his hand up.
Oh yeah, I just want to say during the 1990s, I was an AIDS advocate. And what the CDC was doing was basically developing programs believing that one glove fits all. And they were being run by white gay men, with Afro-Americans being excluded. I was able to get funding from the US Conference of Mayors and the CDC to develop community-based organizations, and I started a movement called Brother to Brother. So I would hire gatekeepers within the community, and they would go out and do HIV prevention. We had meetings, groups, all kinds of things. And we were able to make an impact in terms of changing the numbers for African Americans getting HIV.
Okay, so I think that touches on maybe the next place that I'd like to take this conversation. And this is something that I would love Ms. Highsmith, Dr. Sandoval, and Mr. Van Buren to all weigh in on. We have heard over the last several minutes about the importance of community. And we know that when it comes to most Alzheimer's disease clinical trials, we're talking about these large clinical trial networks, where there's GAPNet and ACTC, which tend to favor the larger academic medical centers, the larger hospitals that have large neurology clinics and practices. Tell me about the value of working in a more localized community setting when it comes to diversity. Does it cost more money? Does it take more time? Why aren't more folks doing this?
One of the things that we've been able to do is, in partnership with Us Against Alzheimer's, we had them help us think about where should we go for some of our trial sites. And so, they gave us some feedback. We did a partnership with them on 3 trial sites in Phoenix, in Las Vegas, and in Cleveland for one of our investigational medicines to help us think about how do we really increase minority participation. So we did some coordinated social media ads to drive online and in-person recruitment in these communities. And we did some other things working with Us Against Alzheimer's. And they were successful in bringing out large numbers of individuals from underrepresented communities. But partly we had challenge with, while the interest was high, the sites actually lacked a good strategy. So like to Fabian's point, the site actually, they lacked a strategy. They might not have had materials in Spanish, right? So like, it's what, we can push to the sites, but the sites have to do their part. So they also really didn't do a good job in collecting the demographic data. So we would understand, who was coming to these things. And so I also think that, making sure, as Mr. Van Buren said, like, how do you engage the partner, the caregiver for an Alzheimer's patient? And so oftentimes the industry is just focused on the patient. But in Alzheimer's, you not only have to be focused on engaging and educating the patient, but you also have to be informing the caregiver about the value and all of the things, the tools and tactics that are going to be available. So it is a multifaceted kind of issue.
And so I guess my follow-up question is, do we need new sites in our fight against Alzheimer's disease? Or is there a way to achieve diverse and inclusive research with the sites that we already have, with the sites that are already getting all of the studies? Are there things that they can do to do better?
Yes.
Do they need their own Telemundo show?
Yes,
or?
we need new sites that are part of the community, right? Because what has happened with COVID has really amplified the racial disparity, right? So like if you have to go to an academic center, that's like up on the hill. It's very challenging. I mean, parking is a nightmare. Navigating the facility versus a local site like a Fabian's site where, they are doing things very differently. They provide Uber and Lyft services for the patients to directly get dropped off at the front door so that the patient can just walk in and it's not cumbersome, right? So like more community sites, patients have access to them. And we do need to challenge our, more academic centers to really think about how are they engaging the catchment area, which means the community around them. But so often it's judged on what does your insurance look like? What kind of job do you have? Are you going to be able to take off work and come in here on these certain particular hours where Fabian's office is open on the weekends, right? So much more patient-centered and focused. And the Ivy Towers, they don't have to do that. They have a lot of funding, so they don't have to do anything extra to engage patients because people are going to come, but those are going to be the wealthy patients. And so we need to be thinking about what is our opportunity to engage more communities of color who might not have the same insurance and the same resources to be able to participate in clinical research.
You know, I tell them all, when patients call, when patients see our ads, one of the first things we have on there, it says, we don't care if you have insurance or not. We want to help you. And we don't care of your legal status. We just want to help you. And on the phone, we let them know that right away. It's like, by the way, I know you haven't asked, but we don't care if you have insurance for this particular study. And we don't care about your legal status. You're safe here.
All right. And Mr. Van Buren,
Yeah,
I'm sorry. One minute, Rear Admiral. I wanted to just check in with Mr. Van Buren and talk to him about what kind of place would you want to get your care? What kind of place would you want to see if you were going to participate in a research study? We know that you've tried and then you've been turned away. Are the things that Quita and Fabian been talking about, are those appealing to you?
Definitely. What I wanted to say was someone in the chat room had asked a question about where do I get my care from? And unfortunately, I'm single and live alone. And being part of the LGBT community, it's not uncommon for us to be individuals living without partners. So you have to develop a treatment team, and that's what I did. I developed a speech therapist, I have a life coach, I have my general practitioner, and even people from the church community. So all these people I keep around me, and they have been really a good asset for me in terms of helping me navigate this disease, especially when I'm at times feeling very much alone. One of the big obstacles is Blacks make up 17% of the population in the United States, but 67% of the COVID deaths.
Yeah, you're absolutely right. And I think that speaks to the magnitude of the disparities that we see that cut across, particular research disciplines or disease areas. Admiral Orojo, I'm sorry that I cut you off earlier. Would you like to make your comment?
No problem. I really just wanted to add to what Quita and Fabian had mentioned with regard to the sites. I mean, I think we have to recognize that our sites have to understand and have that same commitment for diversity that we have across the board. So the sites have to also have that commitment for diversity. We also need to make sure that our site study staff, that they are culturally competent and they're able to work with and engage patients, and that we have the resources and materials available in multiple languages. So we have to make sure that, our patients have the information that they need. And I know Quita and Fabian just highlighted this. So again, I just wanted to kind of reinforce again that we have to have that same commitment at the sites level as well.
All right, and so that brings me to, I think, the next topic of conversation. I think we all recognize that every stakeholder has some responsibility, some culpability in trying to move the world forward in terms of being more diverse and inclusive. We know that funders and federal agencies need to prioritize this. We know that our industry partners need to make this a really critical matter for driving innovation. We know that sites need to take this on board, and maybe we need to be picking new research sites to do this. But who has to start? Where do we begin? Do we need some stricter guidance from NIH and FDA? Do we need more companies like Genentech to really take the lead? Do we need sites, maybe the ones that have been historically funded, to kind of take this and make this a central aspect within the larger emergent clinical trial networks that we're seeing in the Alzheimer's space? Where do we start? Who has to take the first shot to get this right?
So I think it is multiple people, right? Like, it's not just one stakeholder, right? Like, we need to have communities of color participating, and we as a community of color need to encourage like friends and family, loved ones to participate, right? Because the thing is, a lot of us get our information from one another. So the more that we can encourage our own friends and family and community to participate so that we know that the products that are coming out onto the market are safe and effective for us, the better we will all be. And then secondly, we do need the industry. We need hospitals, we need investigators, we need legislators and policymakers to actively stand up and build trust and ask for Black and Latinx people to be involved in clinical research. And then lastly, we need insurance companies, employers, states, the federal government to cover, because right now there are only 13 states that cover clinical trial research for Medicaid patients. So we need more coverage for clinical research.
All right. Do any other panelists want to weigh in on who has to start? Rear Admiral Orojo, Mr. Van Buren?
I can add to what Quita just mentioned. I think she highlighted it exactly. We know that there isn't just this one size fits all solution to advancing diverse participation in clinical trials. And in all of the examples where we've seen success, they're working across multiple sectors. They're engaging patients. They're working with sites. They're industries involved. So we have to make sure that we're all working together to continue to advance representation in trials, because there isn't a one size fits all solution. And on top of that, we know that there are multiple areas and sectors that are involved, and we have to all be at the table. We have to all have responsibility, and we have to all work together.
All right, and Mr. Van Buren, from your perspective, having been turned away from multiple clinical trial opportunities, who needs to start? Who has to get this going? I think you might be muted, sir. I apologize.
I have a responsibility, and when I first got diagnosed, I came out because I was a Black man with Alzheimer's, and I needed to let people see that I am a productive, happy living person. I wear a button that says advocate living with Alzheimer's all the time. And I get into some conversations with many, many people around that subject, and I make hundreds of referrals to different organizations, because these people will talk about their loved one having these symptoms and not really knowing what's going on. And I'm able to explain to them that they have Alzheimer's or dementia. The other thing I wanted to say was, I think one of the big obstacles in terms of care is that only 5% of doctors in the United States are Afro-American. And so I don't think they're really looking out for the general population, like people like me. And I, for the most part, think most people wouldn't trust a white doctor giving them a diagnosis or any kind of information.
Yeah, so it sounds like there are many stakeholders. We all have a responsibility. But Ms. Highsmith, Mr. Van Buren, I think you in particular said that there needs to be some positive movement from within our communities in order to really to really create a groundswell and then encourage these much larger actors to capitalize on it.
Absolutely, we must be vocal.
Yes. Well, one of the good things that's happening is that a lot of these organizations are including people with Alzheimer's. Prior to that, you would never see anyone on a board or a committee that had Alzheimer's. And the reality is that we are the experts on the subject.
So, Mr. Van Buren, would you say that that's a must for clinical trials moving forward, that somebody living with Alzheimer's disease be part of the research design team?
Absolutely.
Definitely. All right. I think that's a great suggestion. At this point, I was going to start to turn to some of the audience questions that have been submitted. But do any of the panelists have other final thoughts about any of the topics that we discussed?
No, I think that having this conversation, and we need to stop tiptoeing around race and health inequity and have the open conversation out in the public so that we can really start to address some solutions versus whispering about it and maybe reading a research paper about it, but actively having discussions so we can make real change.
I couldn't agree more. I think we need to be even bolder than we have been in this conversation today. And so here's hoping that we're able to do that. So my first question, it's not directed to anybody in particular, but I think it is probably directed to Dr. Sandoval, and maybe Ms. Highsmith will be able to weigh in. And the question is actually pretty short. It says, are community health centers effective in neurological trials? There seems to be a lot of skepticism implied in that question, Dr. Sandoval. Would you be able to weigh in?
Yes. So are community centers able to manage those? Is that the question?
Yes, I think that is what the question is.
So I think it depends on the study that's being conducted and being selected as a site. So I'll pivot that by saying, you know, we do some asthma studies, for example. We don't have allergists on board, right? But we see those types of patients, right? So are the sponsors willing to trust our abilities to manage those patients, even though the staff may not be an allergist, right, on board? Because they focus so much on, well, it has to be a dermatologist, it has to be an allergist. And I go back to them and say, those providers are specialists and they're not coming to the community-based or the FQHCs that would see these tons of patients. So the GPs have the experience to see these patients. So give us the study. So if they do award us the study, then in that case, yes, those institutions are able to manage those types of treatments, because we have to remember, we are not doing the study alone. We have medical monitors, we have all types of colleagues that are helping us run these studies, not just from within the site, but that sit further up from the sponsor companies that can help guide us if we run into any issues.
So I guess the follow-up question is, you know, what about some of the hard equipment that may be required? You know, so for example, many Alzheimer's studies today require, you know, kind of advanced PET scanning capabilities. Is that something that you feel would be possible at a community health center, or would you need to partner with a larger academic medical center for these kinds of scans?
Well, yes, absolutely. We partner, and we set, you know, from a business point, we actually have to set up separate contracts directly with those institutions so that we can send our research patients for those procedures, and then we make sure that the patients are charged, you know, for those procedures. But yes, I do it all the time, right? We do DEXA scans and MRI scans all the time in our studies. We don't have like that equipment here. We just send them to the hospitals that do have them, or radiology facilities that have them. And it actually works really well because patients get in and out much quicker, because those companies realize that I'm going to pay them right away. They're not waiting for insurance companies 6 months down the road to reimburse them. I do it, you know, within 30 days of the patient being seen. So it works well.
And I think I will just add, whether, you know, a community health center can do a complicated study or not, what we need though is the center that does have the study to be partnering with the community health center, because that's where the patients are. And so they need to be reaching out to say, we have a study and we're interested in getting people to participate, and here's how we're willing to work with you. Because I do feel like community health centers have the patients. You have to go to where the patients are in order to diversify the clinical research.
Yeah, so it sounds like there's a great opportunity to implement maybe like a hub and spoke model, where, you know, the sites that we traditionally consider for clinical studies can then set up contracts and agreements with local community health centers in order to ensure that the trial remains viable and effective, but that it can reach a much broader set of individuals. There's another question here from the audience, and this one is for Rear Admiral Arrojo. Have there been medical product labels that are differentiated by race?
So where we have data, the product labeling will highlight where there may be a variability in response for particular products with regard to race and ethnicity. So yes, and that information is captured in the product labeling.
Okay, thank you. So this next question is, I think, for everyone to weigh in on, and I would love to hear all four of you respond to this question. And so it's a little bit of a long one, so bear with me. Since systemic racism produces the conditions under which there is reluctance to participate in Alzheimer's research, it doesn't seem likely that increasing inclusiveness in recruitment will address the underlying problem. So I think what the question is saying at first is, if we increase diversity in clinical trials, it doesn't address the systemic causes that make it hard to have that diversity in the first place. How do we, with all of our different levels of expertise, how do we address both recruitment and the underlying causes of disparities in research participation? So how do we create more diversity by race, but also address systemic racism?
I think I mean, I'm not harping on education, but it's a matter of, you know, one person at a time, right? I can't change the world that quickly. None of us can do it that way. It has to be a small ripple effect. We have to show that it's possible, and we're doing it. We're showing that it's possible. We have to bring in also diverse providers. Like Mr. Van Buren said, you know, he's not going to want to go to a white physician because he may not trust him. We need to break that trust as well. We need to make sure that Mr. Van Buren can trust a Hispanic physician, can trust a white physician, right? But it's not anyone's fault. It's just the nature of humankind that's where we have to you know, break those barriers. But it's a matter of doing this ripple effect of saying, now we're selecting African-American providers to become investigators. We need to teach investigators. We need to grow investigators at a younger age. We need to grab these young physicians and teach them the value of clinical trials, right? And it's not that hard if we just do it slowly. I have interns in my office every day, right? We have now 6 interns. There was no room for us because all these students wanted to learn, which was amazing, right? And they're all of diverse backgrounds. So that's what we need to do. That's what I think I need to do. It's a hard we to generalize, but that's the little gold seed that I'm trying to implant to make something happen.
Yeah, I agree with what Fabian just described. I think that when we're thinking about clinical trials and access, and I think we have to also think about those social determinants of health and how that impacts our health outcomes. It impacts our ability to participate and be aware. And I think education is important. We have to make sure that our communities have the education so that they can also understand what a clinical trial is, what it means to participate, so that they can also advocate for participation in clinical trials. We've talked about the importance of our sites. We've talked about the importance of having patients at the table. We've talked about the importance of all of us kind of bearing that responsibility so that we can get towards where we need to be. So I think that the education piece can't be overstated, that it is really important when we think about all of access as well as advancing representation in trials.
So let's have some real talk, right? So like,
let's hear it, Quita.
Let's have some real talk, right? Like, this is a multifaceted, complex problem, and there is no magic solve, right? It is grinding, hard work, commitment, still resolve, and we have to be transparent, like having these conversations, putting the issue on the table, holding people accountable. We have to be intentional in what research we are doing, what sites we're going to, and we have to be bold, right? That is the only way we're going to make change. We cannot keep doing the same old. It is time for us to step outside the box and hold one another accountable. This is our time right now.
All right, so I think with that inspiration, I want to piggyback off of some of the questions about what accountability looks like. Who's in charge of accountability? What are we accountable for? Are we going to be accountable for increasing overall diversity? Should we be accountable for some of these educational outcomes that Fabian and Rasharda have been advocating for? What does accountability look like in this space? How do we know that we're doing it right?
Accountability is people who have the demographics of the people who have the disease are represented in the clinical trial. Accountability is people who have the disease are treated fairly and equitably, right? Accountability is that comorbidities don't prohibit you from participation. That's what we have to be accountable for.
Okay. And so I guess my question is, does accountability just mean enforcement? Does that mean something, you know, as clear cut as if you don't have a representative research sample in your phase 3 trial, you cannot, you cannot apply for FDA approval, no matter what your outcomes are? Like that's a pretty hard line. Is that what accountability looks like, or are we talking about something a little bit less, something a little bit different, something outside of just your what your sample representation demographics looks like? What do we mean by accountability?
So, are we going to have a law, right? I was actually,
that's the question, right? Are we going to have a law?
I'm actually going to email. I've got some people I wasn't talking to about this, right? The law is not there. The only law that I know about clinical trials right now is 10 U.S.C. 980, right? Which is a law. It's that says a soldier can only receive $50 for a blood sample. And the only reason I know that is because I used to work for the Army, right? So 10 U.S.C. 980 is the only law that I know in clinical trials like that. We need something like that. So for accountability, I would love to see something like that, because that would work. The only other accountability I see from my end as a site is that a sponsor says to me, hey, you said you were going to bring in 10 Hispanic patients. Where are they? You know what? I don't think I'm going to give you another study. That's what I want to see, that, because for me, I'm safe because I got plenty of them, right? But that's what we need to do. That's what I would like to see. And that would encourage sites to say, oh man, okay, let me go find some other patients and and not just do what we normally do, because that's what we need to get from the site's perspective. That's what I need. I need other sponsors to say, get me more Hispanic patients, give me more African-American patients. If not, I'm not going to give you any more work. Easy.
All right. What are other thoughts from other panelists? Does this seem reasonable?
I don't know, because here's the reality is, are we going to say because you didn't have X number of diverse patients that the patients you did have don't have a right to have access to treatment? I don't know that we want to go down that path.
But they can show you that, at least show me that you tried.
Exactly. But I do think that the more transparency we can put out here, like the calling out, if you don't have diversity in your study, that people know about it, and that payers say, you know what, I'm not sure that I should be reimbursing for a product that is not, going to be able to cover the majority of the people that have the disease. Like, there are accountability things that can be done without potentially injury to patients who actually need products.
Yeah, you know what? Because you don't want then sites to say, oh, well, we already have enough, Hispanics. We already have enough Caucasians. We can't put you in the study. That's wrong too. I mean, I bring anybody that comes in the door, right? So we need, that's a really good point, Guido. We have to be mindful of that. So everyone's welcome.
Yeah, and I think when you talk about transparency and accountability, I mean, we can highlight, and we've highlighted this earlier, we have drug trial snapshots. You can see what that representation was for certain products. And the other thing, I think when we talk about accountability, we spend a lot of time talking about we need to engage communities, we need to have patients at the table, but you have to be accountable on how you do that. You can't step in for one trial and then you're done and you're not engaging with that community anymore. That's not going to help us build trust. That's not going to help us get patients to want to participate in these trials.
So that actually brings me back to a question that I had earlier. So if we were to do some of the things, Dr. Sandoval, that you've done at your research institute, if we kind of bring that to USC, if we bring that to a major academic medical center, is that enough? Is that enough to drive trust? Is that enough to drive recruitment? Is it just about copying your model and implementing it in another place? Or does that mean, do we need to do something different?
No, copy it. Yeah, I mean, Go get some tables, go get some tents, and go stand at the metro station, go stand by the bus station and talk to people. Tell them about their studies. Do free screenings. My interns right now are setting up a plan to go do some diabetic macular edema screenings at like some farmer's market, right? We'll all be covered up and stuff, but be there. You know, Quita said it several times, go to where the patients are. So yeah, implement my strategy at, you know, any of these other institutions, but do it right. Do it consistently. Make sure it always happens. Not a one and done, just like Captain Rear Admiral Rojo said, it's not a one and done type of thing. It has to be consistent. You have to do it multiple times. So yeah, do it, replicate it. It's super easy. Go out, go into the community. That's what we need to do. And then bring it back to the clinic.
So Mr. Van Buren, would that change your mind if one of these large academic medical centers, these fancy ivory towers, as we've called them, if they did some of the things that we've heard about from Dr. Sandoval and from Ms. Highsmith, if they had like a great television show that aired weekly and that was Emmy Award winning, if they gave you a Lyft or an Uber ride to and from the research center, is that enough to gain your trust? Is that enough to gain your interest? Or do they need to do more?
Oh, I think they definitely need to do more. But bigger is not always better.
What do you mean by that? Yeah.
You're talking about these big ivory tower organizations or clinics or whatever. I would be afraid of them in order to go to them because I would just feel overwhelmed for the most part, I think.
Just because it's a large, imposing institution? And
absolutely, yes.
So it sounds like they would need to try to engage with you in a different way. You know, maybe not have you come in to that large facility as often. So if you could interact with them, at a satellite location, or like at a local CVS or a Walgreens or something, maybe.
And that's a perfect.
Oh, go ahead. I'm sorry.
I was going to say that's a perfect example why we need to have patients at the table and helping us as you design trials. Perfect example.
I couldn't agree more. I had one more question from the audience that I think is directed to Ms. Highsmith, but I think anyone could weigh in. Would Genentech use a clinical trial site that had no neurologists? I think this is a follow-up from Dr. Sandoval's comments earlier.
It's specific to Alzheimer's.
So an Alzheimer's protocol, would you do it? Would you give a site a contract, an award, if they had no neurologists?
I think one of the things that we're looking for, and we received from Us Against Alzheimer's a heat map of where the patients are that have the disease. So what we will be thinking about is more or less, where are the patients versus where are the neurologists? So I don't know that we would use a site that doesn't have a neurologist, but we certainly want to go to the places where diverse communities are, and they gave us, and so we're overlaying the map that Us Against Alzheimer's provided with where we're looking to do clinical research. So I think that if there wasn't a neurologist, if there was a referral pattern for patients, that would be ideal. It would be a community facility that had a neurologist, that had a diverse community access to diverse patients.
So I guess this is a question that's just coming from me now. Would it be possible for companies like Genentech to help build capacity at community sites where you could, cover, a neurologist's time, for a few hours a month in order to help increase capacity and ability to conduct these clinical trials? Is that the solution? Is the solution, instead of trying to create more diversity at the sites that already have the trials, build capacity at the sites that don't, but do have access to diverse populations? Is that something that Genentech is considering or would be willing to try? Or
Yep, absolutely. We just had our, and Fabian is a part of our external council. So we have a council that is made up of clinical trial researchers, patient advocate organizations, and Stephanie Monroe from Us Against Alzheimer's is part of that, as well as academics and community centers. And that is exactly what they have suggested And it is exactly what we're going to be looking to roll out at the beginning of next year, is what we're calling Advanced and Inclusive Research Site Alliance, where we're going to be working with sites to help build capacities in the community. And these sites would be able to do not only very early studies, but the late stage, phase 3, and would be able to do post-marketing.
It sounds like that may kind of be bringing in a new era for thinking creatively, not just about who gets to conduct these clinical trials in terms of sites, but the design of the studies themselves. So,
and luckily, we've got a great group that's been with us for 3 years, pushing us to move the needle, to think differently, because obviously if we had all the answers, we would have been doing better. Which is why we worked with the external counsel to really help us think about things that we are not thinking about, and facilities like Dr. Sandoval that are working with communities to engage them in research, right? So like, it's important for us to kind of go to the experts so they can give us feedback, and based on that feedback, that's exactly what we're going to be doing. We're going to do a pilot with 3 facilities that we're going to see how it works, and then we're hoping to build capacity and expand.
All right, so we've actually just only got about 4 minutes, 3.5 minutes left. So now it's time to go around the panel and hear some final thoughts. Rear Admiral Araujo, I wanted to know if you would be able to lead us off with any concluding thoughts or some kind of summary statement of how you felt about some of the points that we discussed today, or anything that you wanted to bring up.
I think my final thought would be that, one, I think that these types of conversations and this conversation is really important because it helps us to continue to work together and find ways that we can continue to advance minority participation in clinical trials. So I think conversations like this are needed. And in addition to that, we need the actions to back up the conversations that we're having. And we've heard a wealth of information from Mr. Van Buren today on what patients want, what they need, and what they expect. And I think that's really important for us to consider. We need to we have to engage our communities. We need to work with patients. We need to make sure that we have all of us at the table working together, from sites to industry to FDA and others. So I think that conversations like this are very important because it gives us that opportunity to really highlight and share best practices, where we've been successful and where we need to continue to do work.
All right, thank you so much. Dr. Sandoval, your final thoughts.
I believe that we just need to step outside our door, right? We need to open up the doors of your clinics, look outside of the communities that you're serving, and start talking to those people and bring them in, right? We need to look at the fact that, the large institutions have tremendous value because they have services that our smaller community-based clinics don't have access to, is working together with these large institutions to make it happen and allow us at the community level settings to do more work for our patients and continue that trust that we're doing. So we're on the right path. We just need to do a lot more.
All right, Ms. Highsmith.
I will just say, we all have to be change makers, right? We have to challenge the status quo. We have to ask more questions. Patients need to say, I want to participate in clinical research. We need investigators to ask every patient, not just the patient with the best insurance and the best outfit on. We need to be continuously educating communities of color because they will get left behind. And I am very concerned about that. And I want to ensure that we take this moment right now that we have and we make it a movement. And just as much as we're making other changes, we have to ensure that health equity is front and center.
Absolutely. All right, so Mr. Van Buren, final thoughts, bring us home.
Yes. I'm very impressed with the panel, and I'm very honored that I was included in this conversation because, as I said, being a person with Alzheimer's, I have a lot to bring to the table.
All right, so thank you to the audience. Thank you so much to our panel. This has been No Access, No Justice. We've talked about how to address systemic racism in Alzheimer's research and health services. But I think that Quita said it best. Since you are part of the audience, since you are part of the panel, it is on you to be a change maker. So go out there, make some changes. Thank you so much for watching.
Dr. Jackson, thank you so much for that fabulous panel. You know, yesterday I heard two themes. One was about disparities, and the other was about moving from diagnosing the problem to making a difference in the problem. And I hope that everyone who talked about those two themes yesterday and everyone who heard them and was interested listened to this amazing, excellent, and inspirational panel of folks. You know, it is, I think one of the panelists said, a multifactorial problem with multisectoral solutions. And I think that's one of the great things about this conference and about Us Against Alzheimer's, the organization I work for. This kind of problem, it may sound simple, walk outside your door and see who's there, go where the patients are, but there's so many things that need to change in order to diversify clinical trials. And it's going to take governments and policymakers and drug companies and the sites and payers and patients and advocacy organizations. In other words, all of us against Alzheimer's. If you're interested in re-listening to the panel or sharing it with a colleague, video on demand will be up either late today or at latest tomorrow, so you can listen to this same session over again, or again, share it with a colleague. We're about ready to move into our final panel. Yesterday, Dr. Collins, in his chat with George Vredenberg and Dr. David Satcher, talked about a number of things that he's learned going through COVID. And actually, several of them had to do with disparities and diversity in clinical trials. But the parallels between Alzheimer's and COVID have not been lost on those of us who work in this field, but also live in this world of COVID every day. As I said yesterday, best estimates are that more people will die in 2020 of COVID, of Alzheimer's rather, than will die of COVID. More people will die of Alzheimer's than will die of COVID. So what can we learn from this more news-making, more urgency creating pandemic called COVID? We'll come back at 3:30 Eastern for discussion between George Vredenberg and Governor Michelle Lujan Grisham of New Mexico on that topic. And then our final panel of this summit with several people who will give us their ideas on how we can do it. And then again, a reminder tonight, 7:30 Eastern, you're all invited to the Trish Vredenberg Gala. Thanks, everybody. We'll see you in a few minutes.
The COVID-19 pandemic has had a devastating impact on the Alzheimer's and dementia community. Caregivers report ongoing severe stress. And this stress is affecting the care they can give to their loved ones with dementia. Caregivers feel unprepared for what will happen to their family member with Alzheimer's if the caregiver gets sick. People living with Alzheimer's and other dementias are seeing more rapid decline in memory and behavior. Reverend Tracy Lind has frontotemporal dementia. She says often during COVID, her head feels full and her language deteriorates, leaving her feeling out of sorts and emotional.
We walked down the corner to watch the Cleveland Heights graduating class in a car parade, driving down Lee Road in their cars, and everybody honking and cheering the graduates. And I just sat there crying. I'm not emotional like that, but I can't help it anymore. I just kind of keep having to reset over and over again, but every reset gets harder.
In nursing homes, visitation restrictions result in months-long separations of loved ones and their families. Loretta Vini couldn't visit her mother Doris, who has Alzheimer's, for 3 months, the longest they've ever been apart.
My greatest fear was that she would forget me, but the deterioration that I noticed on each backyard visit has really been amazing. They have to bring her outside, of course, so she needs a lot of help to walk, which she never did. Now they have to physically help her out. It's been excruciating. That's the best word I can come up with, and the guilt is just overwhelming.
And tragically, the number of deaths due to Alzheimer's and dementia was more than 20% higher than normal during the summer months. Experts say this is most likely due to increased isolation and stress, poor nursing home care, and COVID-19 itself. As a society, we must do more to protect those living with dementia and their families, including testing and resources for nursing homes so residents with dementia get the best care, and solutions to allow more family visits. We need rapid response support systems for caregivers and more widely available technology to ensure everyone who needs it can access the support. The problem is clear, and the need for solutions is urgent as the COVID-19 pandemic continues.
I dread the coming winter when we all go back inside and have to figure out how to keep each other busy and engaged and challenged and not become totally isolated. That is my fear.
National, state, and community leaders in government, long-term care, caregiver support, and advocacy must seize this opportunity to better prepare for the next crisis. How can our nation build resiliency against future pandemics to protect the dementia community?
Good afternoon, and welcome to what hopes to be an interesting conversation with one of our nation's most prominent governors, Governor Michelle Lujan Grisham of New Mexico. Thank you for joining us today. The demands on you and other governors I know are rather extraordinary at this time during the COVID crisis, and so we deeply appreciate the time that you're spending with us. Governor Grisham is the 32nd governor of the great state of New Mexico, the first Democratic Latina to be elected governor in US history. She's had a very productive couple of years in office, and in 2019, she oversaw one of the most productive years in state history, signing a broad package of bipartisan bills into law, notably a historic investment of public education and a landmark initiative in transition to clean energy. So thank you, Governor Grisham. Just a few introductory remarks, and then we'll get into the questions. The COVID-19 pandemic has taken hundreds of thousands of lives, sickened millions more, and put life on hold for all Americans, with especially harsh consequences for communities of color and for families of dementia. The COVID pandemic has caused an alarming increase in deaths of those experiencing Alzheimer's because, in part, this disease attacks the neurons in the brain as well as the elements of your lungs and your heart and other elements of your body. It has also deprived family caregivers from the ability to use daycare facilities for their loved one, to visit their loved ones in nursing homes and in assisted living facilities, and to bring in daycare help into their homes in order to provide assistance in caring for those that are home. So we've been affected both by increasing the number of deaths in our community, as well as by the impact on the caregiver loved one relationships. You memorably held up a photograph of your mother who lives in an assisted living facility in Albuquerque, imploring New Mexicans to socially distance and mask in order to protect older people who are at high risk. Understandably so, since long-term care facilities across the country have seen a major increase in deaths and a major source of outbreak. But Alzheimer's caregivers with loved ones in long-term care report higher stress because they can't see their loved ones, and importantly, the health of their loved one and help with their care is less accessible than it was before COVID. So my first question is just a little bit about your background and about your experience with Alzheimer's, but how you as governor are beginning to try and balance this need for connectivity of families that are experiencing dementia and at the same time trying to keep them safe.
Well, George, I really appreciate being invited to participate with you all today. And you bet we are all against Alzheimer's and excited about your work and what you do. And I think that you framed it really effectively, which is a pandemic is a national, global crisis of the kind of proportions that we haven't seen in 100 years. And so you have to start with, there's no balancing, it is unfair. You have to recognize that if you don't get it under control, the kind of other consequences, including what we're seeing for both populations on either end of the spectrum. If you're in a long-term care facility, or you're in a correctional environment, or you're a kid who can't go back to school, the social isolation and the inability to support the social and mental well-being of our populations has proven to be an enormous challenge, where you have to weigh, do we risk death by COVID, including to all the other residents and all the other workers, or do we risk having depression and isolation, which has led, I think, to increased mortality rates and related exacerbated underlying conditions. And so we've been a very strict follow the science, and we're a state that has 1/3 less healthcare capacity. And that means that for per capita, we have less than any other state in the nation, and yet we're poorer and sicker as a population than anyone else in the United States. So when I have an outbreak, and we have at nursing homes, there aren't any other caregivers, right? So now we're in a situation like we saw with horror in Spain, where they abandoned nursing homes and went on to other vehicles to provide care and left people to die, which is the most untenable, horrific set of circumstances that we're seeing play out. Quickly, like most states, we're trying to figure it out. Increased testing, rapid testing on site, outdoor visiting, lots of window visiting, notebooks and iPads, and any number of ways to make sure that you're doing video conferencing. And all of that is helpful, but there is nothing that replaces human touch and familial or loved one interaction, including in our safeguards like the Ombudsman program. And we are really struggling here like we are anywhere. And you talked about my mom. I haven't been able to see my mother in person since last December. And she's not doing well. And she's been to the hospital twice. And I couldn't go with her to the hospital. And she keeps getting quarantined. And she can't wear a mask. And she doesn't suffer from Alzheimer's, but she does have dementia. She's got cognitive issues, and she doesn't understand why she's abandoned and where I am. And it is an incredibly devastating situation where I see my mother's health failing before my eyes because I can't get in there. And right before this conference, her physician called me to say she's not doing well again today. and we're going to try to wrap around in some way. The answer to this issue is threefold. One, we have to have better preventative strategies. We need fewer people in long-term care facilities. We need better strategies with backup for a pandemic for families who find themselves also without access to critical care. And three, as a country, we need to do much better at public health and infection control, because the countries who got it under control aren't having these debates about social isolation for their vulnerable populations. We are. As Americans, I've crushed this virus in New Mexico twice, and now I have to do it again because there's a resurgence. So people won't wear masks, they won't socially distance, they won't protect those caregivers, and that is a problem. And this is a country that needs public health and public health prevention education. I'm going to tell you early childhood education all the way through the end of your education, because we clearly don't understand how to manage it. And that really, in fact, is the answer.
Well, I think there's no question that you're absolutely right. We speak of the populations that have pre-existing conditions, which are more vulnerable, who are more vulnerable to pandemics, this one, but also to other pandemics. If in fact we could strengthen ourselves by improving our health of pre-existing conditions, namely chronic conditions, we'd be much stronger as a community in resisting pandemics. So you're absolutely right. But what is interesting and what's challenging about this is that the pre-existing condition set, the chronic condition set, it disparately affects communities of color and low-income populations, which means that our strategies have to be directed in particular, not solely, but particular about improving public health conditions, chronic conditions in low-income and communities of color. So I'm curious as to whether you view it that way, and if that's so, what you might be doing as governor to try and mitigate these disparities that we're seeing in pre-existing conditions, chronic conditions, and hence vulnerability.
I totally agree with you. I mean, this is one of the reasons why I'll digress. I promise not, and be not as long-winded.
Oh, go ahead.
I like you. In this state, a rural frontier state, one of the poorest states in the nation, using old, antiquated, unfortunately, I can't change Medicare calculations. We don't have the resources here to build the kind of healthcare system. Not that the country does it very well, but we are in far worse shape. And yet we haven't overrun our hospitals, even though we're surging. We've done very well with our healthcare clinics. There's no out-of-pocket costs for testing or for COVID-related illnesses. Our insurance costs are coming down, our premiums on the exchange, and we have 43+% of our population on Medicaid, with the most robust set of Medicaid investments and benefits. Frankly, I still think of any other state in the country, and we are building that out all of the time, looking at public options and other ways to really build an effective healthcare system that is based on prevention on the front end. So if we weren't doing COVID well, and there was a New York Times article on, and we're surging right now. So if you're watching CNN, you can see that we're struggling to keep the infection at bay. But our mortality rate, given that we're a minority majority state with the largest individual numbers of sovereign nations, pueblos and tribes in the country, our mortality rate should have been much higher. Why wasn't it? Well, we did a lot of containment and a lot of good public health strategies on the front end, but we also know that if we don't get it right, it would be much higher. 1 in 3 adults in New Mexico suffers from high blood pressure, heart disease, kidney disease, the most serious of those chronic consequences that make us more vulnerable to, say, H1N1, so those flus, and to this particular virus. It is clear that we aren't doing the right preventative work, and Medicare is shifting in that direction. Medicaid has to catch up, and we must fight to make sure that we're teaching and treating social determinants of health by population health in this country. And until we do, we're going to spend far more in the back end, which means we aren't going to be dealing with preventing Alzheimer's and dementia and applying curative measures, which I think are now in the pipeline. You know, this is a country that keeps catching up, and we never had to be in this position to start with. And you are right, George. My mother's dementia is completely related to all of her other underlying conditions and bad public health choices on her part, including smoking.
Well, as you know, we're in the brain health business, so to speak, so singing the same song you are. But as we think about how to build out greater capacity in the health system to be able to understand, detect and understand how to treat brain health issues, at least neurological conditions in older populations, although we're beginning to work with the mental health community on younger populations. One of the critical things is how to build out a healthcare system that's better prepared for brain health issues of aging populations. And so one of the strategies that we are considering is how to build greater capacity, both in terms of resource and in terms of expertise and tools and tests into the community healthcare system. So I'm curious as to what the quality and nature of your community healthcare system in New Mexico, and whether that is a strategy which deals with a capillary of the general healthcare system, which is more attuned to low income and people of color populations.
New Mexico has a lot more to do, but we do actually have I think, a very effective community health and more holistic healthcare system, because we've had to do that given the rural and frontier nature. You know, we've got some communities that have very limited access to practitioners. So if we don't use an integrated private and community healthcare model, we have one of the most successful telemedicine, telehealth models in the country that has been now the focus of considerable both international and federal investments. And they are looking at Alzheimer's and related issues so that primary care practitioners, who often are internists and geriatricians, get even more support and more education and training to think about ways to detect it early, diagnose it early, and to do the kind of preventative investments and work that families really need in order to both prepare and prevent to the highest degree that you can. And I feel really good about those efforts and investments, but none of it's enough. Although I might just point out that in my first legislative session, we invested in centers of excellence. Our bioscience center of excellence is in our one of our universities that's got our medical school, which is an incredible medical school given the size and nature of the state. It's fantastic. And you know, UNM, the University of New Mexico, is being credited as one of those research institutions that's in the market for doing the research to cure Alzheimer's, and is listed as one of those institutions that's in that race to productively get that over the finish line. And it's really exciting work. And I think states who suffer from more chronic conditions, more dementia, more cognitive impairments, more Alzheimer's need to be in that leadership role, because we can solve any number of these issues all across the country and all across the world. And something, George, I didn't say, Alzheimer's dementia is the cruelest disease. And it doesn't care who you are or where you are, how healthy you've been, although we know that there are exacerbating and pre-existing situations and conditions that create other problems and risks. But when you add that to COVID, I just want to make sure that everybody's hearing our conversation. This has been a very painful dynamic for everyone. And it is the kind of thing that keeps me up at night. And I'm looking at newer strategies in addition to prevention and cures and treatments that would create cooperatives so that caregivers who make the lowest can own their own assisted livings and be in an environment or have collaborations with families so that we create a pipeline and wealth and equity for the men and women who are largely Hispanic in this country or minority populations who are providing support to familial caregivers. And I know I'm preaching to the choir, you know, more than $500 billion worth of care. And while my mom's on Medicaid, and thank God for that, and Medicare, and gets help from any number of programs without my involvement. I assure you, she would cost the healthcare system more. She would not have lived this long, and she would not have any quality of life despite the loving attention people try to provide. It's not the same. I do it better. I'm more effective, and her doctor will tell you I'm better at diagnosing what's going on with her because I don't have to figure out her baseline. I know her.
Yeah. Well, as a member, the reason I started this organization 10 years ago is because 3 generations of my family have been impacted by Alzheimer's over a 40-year period. And I thought that if, in fact, we didn't accelerate efforts and adopt new strategies and get more resources, 40 years from now, if the situation were the same, it's my kids and my grandkids. Of course, men are always in denial, but it would be my kids and my grandkids.
Doesn't seem like you are, George. You're awesome. And I know we're running out of time, but I also want to pitch Medicaid, Medicare, healthcare financing, making sure we don't miss an opportunity to deal with this.
Absolutely.
Alzheimer's, if we don't,
my organization will be seeking more resource for community health centers and strategies in leading areas to try and use community health centers to really try and get at both the prevention elements of this, as we're seeking a national prevention strategy, as well as improvements across the nation. So we will be back in touch, Governor Lujan.
Good, and let's expand CareCorps, which is a kind of a national Peace Corps replication strategy aimed at having more volunteers trained and supported, never to replace paid caregivers, right? You know, our men and women who dedicate their lives to making a difference, but it is a way to support families and the individuals who are suffering and are losing independence and want us to treat them with dignity and respect. So I'm excited about that. Maybe we can work together on more funding and more support for that. And so let's do 3 things. Let's attack this pandemic and solve it. Let's take care of our families and their loved ones who are in long-term care and at home. Let's cure Alzheimer's. Let's prevent Alzheimer's and chronic conditions. And let's create an environment where Americans are the healthiest of all populations in the world. And let's focus on a group that really needs us, that will also, frankly, save the country. If we're worried about the federal deficit and the national debt, look no further than making sure we do something about our long-term care expenditures.
Well, the only other thing I would say together is let's all vote. Let's all vote. Let's get an administration one way or the other. I'm not going to take a partisan view here, but one way or another that will actually take exactly your 3 priorities and go execute on. Thank you so much for your time, your insight, your comment, your energy. And I love your vision, and we will be partners in the future. I am confident. So thank you for joining us.
Thank you.
All right, take care. Now we're going to turn to our panel discussion on COVID-19's effects on our community and what can be done about it. This panel is going to be moderated by Meryl Comer. Meryl Comer is one of my co-founders of Us Against Alzheimer's. New York Times bestselling author, a fierce advocate after years of caring for both her mother and her husband for 22 years at home, her mother for 10 to 12 years at home. So she's had a long journey with this disease, knows exactly the experience of being a caregiver for 2 loved ones at home. And I thank her for her friendship. She's been a friend for 20 years in this fight, but a friend socially as well. But we are partners in this battle. And we thank you for your loving care of your husband and your mother, for all of your work on behalf of patients and caregivers. And thank you for being such a great partner and a great friend of mine.
Thank you, George. The theme that has run through the summit is the disproportionate alarming side effects of the COVID-19 pandemic across the Alzheimer's and dementia communities, including, as you've just heard from Governor Lujan Grisham, the personal heartache of those with loved ones living in long-term care facilities. The stats in the earlier opening video are from the latest longitudinal A-list COVID survey series that has been taking the pulse of the patient and caregiver community over the past 7 months. And for those A-listers joining us today, we're over 8,500 strong. We hear you loud and clear on what matters most, and we hope you'll see in this session what matters most, how your issues drive our advocacy. Joining us now is our esteemed panel, Dr. Kenneth Davis, President and CEO of the Mount Sinai Health System in New York City. It's one of the nation's largest integrated health systems, which includes the Icahn School of Medicine at Mount Sinai, 8 hospitals, and over 300 ambulatory sites. Dr. Davis is a neurobiologist and one of the most highly cited researchers in the field of brain medicine. Welcome. Also joining us, Terry Fulmer, PhD. She is the president of the John Hartford Foundation, world renowned for its philanthropy devoted to the health of older adults. She is one of the leading experts in geriatrics and best known for the National Niche Program, her research on the topic of elder abuse and neglect, and her recent Age-Friendly Health Systems Initiative. Our third panelist is Edwin Walker, Deputy Assistant Secretary for Aging of the Administration on Aging within the Administration for Community Living. I'm going to come back to you on that. A lawyer by training, Mr. Walker serves as the Chief Career Official for the federal agency responsible for advocating on behalf of older Americans. Thank you all for joining us. Dr. Davis, you're operating on ground zero. We're into the middle of a second surge in the pandemic, double whammy projected with the flu. Give us an update.
Well, right now, it's not nearly as bad as what it was in the spring. When we were at our peak level in the spring, our hospitals had over 2,000 COVID patients. At our low point, which was about a month ago, our hospitals had 17 COVID patients. Today, we have about 110. So had this been the initial pandemic with 110 patients, we'd be celebrating. This is so far not a second wave, at least to the degree that we have feared. It's a very manageable number, and we've learned a whole lot more about how to manage this disease.
On that very point, what systemic issues did the COVID crisis expose in the health systems, and are we any better prepared for the next round?
Well, let me give you a little story around that, and I think it'll give you a sense of were we prepared and did we know what we were doing at the beginning. Our system, our hospital system, is fortunate that we have a number of affiliated hospitals in China and medical schools. And as a consequence, when Wuhan happened, we began to talk to our colleagues there and began to appreciate what could happen in this country. So before the epidemic hit, we were purchasing protective personal gear in China, and it was loading onto planes well before anything happened. Our Chinese colleagues had no more idea of how we would treat this disease than we did once it came. And we really had no idea the kind of numbers we'd see. About the second week in March, a few of us who run large hospitals in New York received a call from our governor, Andrew Cuomo. And Governor Cuomo said his epidemiological models suggested that we would need to double the number of beds we had in our hospital system. We were amazed and frightened, but immediately began to do everything we could to prepare. Ultimately, we only had to increase our bed capacity by 50%, but still that was a lot of beds. Doubled up everything in the ICU, put beds in atrium, opened a tent in Central Park. We had to do a lot. And along the way, we learned. We didn't know when to intubate patients at first. We were probably doing too much. We didn't know when to give remdesivir. We knew that there was an immune response, but we didn't know early on where to give the steroids. We knew that antibody treatment might be useful. We didn't know exactly when, and we had to create from convalescent plasma antibodies. When we looked at autopsies, we found out that we were seeing little thrombi, little emboli in lots of organs. And we realized that we, at some point, needed anticoagulation therapy. Ultimately, then, over the next couple of months, we learned how to take care of patients. And now we're far better. And the death rate from those people who come into our hospital is a lot lower.
Thank you. Dr. Fulmer, you're a geriatric nurse practitioner, multiple nursing degrees. What are the sentiments in the nursing profession about the pandemic and the conditions in which they've had to operate?
Thanks, Meryl. And like every discipline, all of us have needed to practice in a very different way. And we've needed to think creatively as part of the healthcare team to make sure that we've been as effective as possible. And thinking about nursing, that's a big tent, Meryl. There's like 3.5 million nurses in the United States and another 4 million certified nurse assistants and home attendants. So where we practice has had a lot to do with how we feel about the way we move through the pandemic. Let me give you an example. A friend of mine who works in an intensive care unit in this country was really overwhelmed with how quickly supplies came to her in that moment, with masks, gowns, gloves, all the PPE that we've talked about, and the way in which staff were shifted from one unit to another to go help in those circumstances that were so dramatic. Now, if you're a nurse in a nursing home, you had a very different experience, because nursing homes were really an afterthought in this pandemic as we started. That's not the case today, but as we started, all equipment, supplies went to our acute care facilities. And as we've learned, that could have had a great deal of negative impact on individuals in the home setting, in the nursing home setting. So that's why you'll hear me talk about some of the approaches to change that for the future. But I think that your experience is going to be also rooted in whether you were in urban or rural, whether you were in a hospital that has means to cope versus not. So we've seen a lot of different experiences around the country and around regions.
Mr. Walker, your agency has a unique and challenging mandate, even in the best of times or normal times. What does it do, and how did your agency adjust to meet the enormous increased need when COVID struck?
Thank you, Meryl, and it's my pleasure to be here today. As you mentioned, our agency, the Administration for Community Living, Administration on Aging, has the responsibility to implement the Older Americans Act, which was created in 1965 and created a national infrastructure of health and human service agencies that consists of dedicated individuals at the national, state, and local levels. And they give of themselves. They are people who are truly, when I say dedicated, they go well beyond the call of duty. They believe in the mission of caring for older people to enhance their independence, their dignity, but also to enhance their optimal health. And so because of COVID, we found that they became very innovative, very creative. They were very adaptable. They adapted to the changing situation and they responded to the needs at the local level. That's one of the things that they're supposed to do on an ongoing basis. Our funding is flexible enough to be responsive to local needs. And I, as an individual in this network, am so proud to be a part of this incredible network.
But what were the systemic issues that were uncovered? Because that is one of the byproducts of COVID, looking at systems that aren't working.
Well, we didn't have therapeutics. When you look at what is the incentives for the pharmaceutical industry, are to develop drugs for chronic disease, drugs that you can take all the time. No one has focused on coronavirus and developing treatments for that, because an acute treatment is a short-term duration of administration. But I think what we've really learned the most is what we've known for some time, but it was emphasized here, and that is that underserved populations, minority populations, have a disproportionate share of disease. And that's because we continue to not address the social determinants of healthcare. And we have to rise to the occasion and realize that the most unfortunate members of our population really need our care, and we have to invest there. Otherwise, they will always have the worst outcomes.
Dr. Fulmer, you've been quoted as saying the greatest success story of the 20th century has been the increase in longevity. However, we haven't addressed how to take care of those who make it into old age. Now, in what way did COVID expose this type of neglect?
Sure.
Is that a good term, neglect?
It is a good term, Meryl. And, you know, I do say that we love longevity. We love to say our grandmother is 98 years old, but we don't like to take care of people. And we've seen that in the way in which we have distributed resources, in the way in which we have supported workforce, in the way that we continue to hear ageist comments throughout this pandemic. We heard people say things like culling the herd. I must tell you, how horrible is that to hear phrases of that nature? And so I think that, you know, for our foundation, since 2015, we have been doubled down on creating age-friendly health systems. And an age-friendly health system starts at your kitchen table, might take you through the emergency room to the ICU, back to your home, but it's a system where there's information that crosses care boundaries, and people use a shared language, and they understand fundamentally what's going on with the older adult. And we've seen a failure of that. And so it's something that we're working hard on. And also we've seen a gutting of the public health system over the past couple of decades, to the point where, you know, all of a sudden everybody's saying, wow, we really need health. The governor said it, we need health promotion, disease prevention. So we're also working with Trust for America's Health in Washington, D.C. on creating age-friendly public health systems and that shared narrative, so that if somebody were to go home in a public health office in your neighborhood, knew it, couldn't we do better than what we've been doing? Julia Adler-Milstein is an esteemed researcher at UCSF, and we worked with her to learn how we were doing in terms of post-acute discharge information transfer, and the data were very disheartening, in that people can still show up to a nursing home or home care, and it might take 2 more days to find out what medications they're on, what their allergies were, and who's supposed to show up. So we can do better than that, and I think that everybody is very focused.
I think we'll be getting back to that topic. Mr. Walker, as of July of this year, the rate for dementia and Alzheimer's fatalities was nearly 20% higher than the average in recent years. And there has been a disproportionate impact on communities of color that has even extended into the essential service workers. What are the systemic disparities that you wrestle with on a day-to-day basis?
Well, one of the things that we are charged to do is to serve those in greatest need. And specifically with regard to the grants that we give out to states and local communities related to Alzheimer's disease and assisting caregivers, we focus on those that are historically underserved, or those that are communities that are ethnically diverse. And so that's how we attempt to address those issues with the population you identified.
Dr. Davis, let's be quite direct. The experience of many families with a loved one with dementia in a hospital is not a positive one. Hospitals never seem to have been equipped or designed to manage dementia patients with comorbidities that need that direct care. Can you address what happens in normal times and what happened in this time, and how it compounds your effort to care for people?
Well, what happened in this time was incredible, because we had to bring in staff from every discipline, orthopedic surgeons who wound up as transporters. So the last thing we had was the ability to put somebody at the bedside of a demented patient with COVID and give them the kind of care that they might have demanded. In normal times, it's difficult, but not impossible. I mean, we try our best to add staff in those cases. We are a healthcare system that is particularly sensitive to dementia, being one of the first Alzheimer's disease research centers. We recognize that those people need more care. But you have to remember that at the end of the day, what we are reimbursed for the average Alzheimer's patient is determined by Medicare. And in many environments, Medicare relatively underfunds the cost of care, so that every patient who walks into your hospital, you're losing money on. And in that circumstance, when margins are that narrow, it's very hard to do what maybe really you'd wish you could do.
There's another term that comes up, and that's granny dumping, where senior citizens end up in the emergency room because families can't manage them. Terry, do you want to comment on that as an issue?
That's been a phenomena that's been observed since the 70s, Meryl. And there was one particular episode that ended up on the front page of the New York Times, and it was an older man with Alzheimer's who was left at a dog track in Minnesota with a T-shirt on that said "Proud to be American." His family dumped him there, and they were caught. They were persecuted. They were prosecuted. But what we know during these times is that caregivers are stressed out of their minds. They don't have resources. They do imagine that the emergency room will give them some relief. Having served as an emergency room nurse, I understand that. What I would say is that how do we get to a point where people's only refuge is an emergency room? That's a societal issue. And I think Ken pointed that out already. You know, like, what are we valuing? Do we know are we supporting our family caregivers? Are we aware of who in the community is going to be most at risk? Are we working with our adult protective service colleagues in order to really identify and preempt and predict and make sure this doesn't happen? When I worked at Yale, we did a study of emergency rooms and we screened for elder abuse and neglect. And it turns out that far more people were neglected than actually physically assaulted or abused. But for those individuals who were neglected, they were much more likely to die, because if you don't feed somebody, if you don't give somebody water, there's going to be really serious consequences. So I think that it's societally, we need to shore up adult protective services, make them a part of the care conversation, work with ACL in all the ways that they are in the communities with the AAAs.
Mr. Walker, the statistic that always confounds me, and as a longtime caregiver, 50% of social services never get used by caregivers because they can't get out to use them. Now, do you find that in your advocacy on behalf of older Americans that many times we don't take or participate in programs because we don't know they exist, or there's still a stigma about needing to ask for help?
Both. Both is the answer. Certainly, we've often said that we're the best kept secret, one that we don't want to keep as a secret, and we wish that others did know about us. I think our message would be that we are here. Our mission is to care for other people, older people themselves, but also the caregivers of individuals who need that type of assistance. And we are seeking we're seeking you out. We're looking for you. We do have a 1-800 call line. It's called the Elder Care Locator. You can go on the web and anyone can access help in their local community. It's great. But as it relates specifically to caregivers, we are aware that most caregivers don't even think of themselves as a caregiver. And we believe that the first step is to first acknowledge that you are a caregiver. Second is to know that we're here. Third is to then ask for help. It really is okay to ask for help. That's what we are here for, and that's what we're desiring to do.
Thank you. I'd like to go back to the A-list survey, because 75% of those taking care of people with Alzheimer's disease at home were so anxious about what would happen to their loved one, Terry, if the caregiver got sick. And that is similar and averages across the board. Now, we are talking about an unpaid labor force of over 16 million caregivers. providing 18.6 billion hours of care last year, a contribution to the nation of 244 billion. Does the government have a plan B if we get sick?
So a government question would probably be Edwin, but I would just say that you're underscoring the need for respite and peer support and programs that really get in there and shore up all the different supports that are so desperately needed. And I do know that through the ACL, there is federal programs that are being expanded, but let's let Edwin talk about that.
Thank you, Terry and Meryl, for the question, actually. And we have what's the National Family Caregiver Support Program. It was created in the year 2000, but we also have the Lifespan Respite Care Program designed to address the very issue you have. Most recently, Congress passed 2 pieces of legislation focused on RAISE, which focuses on caregivers and the supporting grandparents raising grandchildren. And Terry's foundation has been wonderful in supporting the RAISE Family Caregiver Advisory Council and helping us get information out, building a strategic plan for this country that we will then give to the Congress as a roadmap of where we need to go. We have been holding meetings, hearing from these experts from around the country in terms of caregiving, giving us ideas of what we need to do. We've also looked internationally at what other countries have done with regard to caregiving. We're always looking for the best solutions, and we intend to roll those out in this country so that we can provide the compassionate care that we know people need and that they deserve.
Dr. Davis, I'd like to come back to you because it seems quite obvious that we haven't begun to understand the collateral damage from COVID. What are your concerns about what we call the long-term chronic effects of the pandemic, from brain fog?
I'm very concerned. At least a third of patients who get admitted to our hospital and a higher number who get admitted to the ICU wind up with a chronic condition that can affect brain, kidney, liver, lungs, or heart. So this is a chronic condition now. And what we call brain fog is really troubling for those of us who really have been a part of the Alzheimer's community. What we don't know is, are we increasing the risk for Alzheimer's here? Are we speeding up the time at which people will have their first significant symptoms? Since we know that Alzheimer's changes start 25 years before people have symptoms, we can assume that the kind of changes that COVID is causing is only going to make that happen sooner. So it has to be a real concern. It has to be something that we study and something that we may think about how we can prevent.
Terry, do you want to pick that up as a long-term chronic issue to manage?
Sure.
It's all management now.
It really is. And that goes back to workforce. And so we have to make sure that we have a workforce that's prepared, can understand the symptoms, and can be carrying out the different modalities that are so important. Let me give you an example of what I'm thinking about, Meryl, and that is during the pandemic, we saw, as you pointed out, people who were isolated in their rooms, in their homes, in their communities. And so what happened? People began to have mobility issues, maybe some delirium, maybe some true changes in cognition that were missed. Their medications may have gone unfilled. And so you're hearing me talk about the 4 M's of an age-friendly health system, where every single person in the care system, whether it's a home attendant or a surgeon, can figure out how to use our 4M set of what matters to the older person and their family, is what's most important to them, really at the center of the care plan, and let's hope it is. And we know that that is so essential. Mobility, look at how people have had stories where they haven't been out of their rooms for days at a time, and there's muscle wasting, sarcopenia, as we call it in the healthcare business, but muscle wasting that will take a long time to bring back. I mentioned medications where they may not be filled, or people might be taking their medications incorrectly and not knowing it. And then the whole notion of mentation, your mood and memory. So if that's changing, so if we could all just think about that simple set, that's what caregivers across the country and around the world need to be thinking about. We need to distill it, and we also need to teach the public to demand attention to those elements of care so that they can get the care plan that works for them.
Let me just follow up with that for both Mr. Walker and Terry. The social relationships as predictors of health. Have we moved in that direction? There was a recent intergenerational study by AgeWave in the Edward Jones Retirement Survey, and it reported, of course, loneliness is pervasive across generations, but as people age and that physical isolation, it becomes an even greater health risk and is linked to increased risk for heart disease and dementia.
So Meryl, yes, the AgeWave study, but also the National Academies of Science, Engineering, and Medicine almost presciently released a study on social isolation and loneliness in February. Imagine that. And so what they showed is that if the subjective sense of being isolated and the objective sense of, excuse me, I got that backwards, the objective sense of being isolated, the subjective sense of loneliness has been compared to smoking. Isn't that something that it can be that detrimental? So I would recommend that anybody take a look at that. There are recommendations in that study from the National Academies to say what we need to do about it, but make no mistake, it's very detrimental to health.
You know, when you look at these various surveys, Americans 65 and older fear Alzheimer's more than COVID. So Dr. Davis, you've conducted pioneering research that led the FDA to approve 4 of actually the first 5 drugs for the symptomatic treatment of Alzheimer's disease. What does this pandemic portend for the future of research and aging populations? Because as a society, we are headed right into the slow boil pandemic, that's a George term, of Alzheimer's disease.
Well, hopefully the increased risk that was associated with aging is going to be something that will be intensively studied, that there will be more dollars to the NIH to ask, what are the vulnerabilities of elderly people? What makes this happen? And can we do something to strengthen those barriers that can protect the elderly brain from some of the insults that are a part of our environment?
The notion of brain health and what we can do, you're one of the top researchers. My husband maintained his brain and it just didn't matter.
Yeah. Well, if you have bad genes, there's not a lot you can do. However, we do know that if you decrease your cardiovascular risk factors and you exercise, it's the best way to delay what could be the inevitability. So if it's a 25-year process from the time the plaques and tangles begin to develop in your brain until you have symptoms, the goal here is to make it a 50-year process. And there are things we can do right now that we know that can slow that down. As I said, good cardiovascular health, decreasing all those risk factors that are associated with cardiac disease, keeping a normal blood pressure, normal lipids, and getting regular exercise. Those things are going to slow the ultimate progression. And hopefully we'll find a drug that can do something as well. But right now, what I tell people is just whatever you're doing to protect your heart, it's going to protect your brain, and make sure you exercise.
I don't know whether it alarms you, it alarms me that the baby boom generation has already begun to reach age 65 and beyond. So that's the sweet spot in terms of risk for Alzheimer's disease. And now the oldest member for the baby boomers turns 74 this year. So we can see this wave coming, Edwin. Is your agency prepared for this coming wave of boomers? There are 58 million in the country right now that are 65 and older.
Well, while we are the Administration on Aging and we focus on those who are already there, we really focus on all ages. We believe that it is never too late and that everyone should plan effectively for their longevity. Everyone loves the idea of living a long life, but they want a good quality long life. Science has proven what contributes to living a good quality long life. And it's just like he said, we have a two-part strategy as it relates to Alzheimer's disease and dementia. The cure strategy at NIH, NIA, and the care strategy, where we're focusing on those who are struggling with the disease now and those who are caring for them, and teaching them evidence-based and evidence-informed interventions and tactics that will help make that care journey easier and tolerable. And so we just are really focused on both strategies and addressing all populations during this time. It's the only way to go.
I'm talking to a group of panelists who really collaborate and have a similar mindset. I want to go back to something you said, Ken, about the Medicare fee for payments. And you've all been leaders in trying to move away from fee-for-service medicine to sort of value-based population health, with the aim of keeping more people healthy and out of the hospitals. So tell me what that looks like, and where does it sit based on where we are right now?
Well, we hope that it would have come sooner. We were all very enthused at the notion of pay us to keep people well. Give us a per capita rate for a group of patients, and we get that amount of money no matter what happens. So instead of being rewarded when people get sick, we're rewarded for keeping people well. It's been slow in coming for various reasons. We hope it'll happen sooner, but ultimately it has to happen because employers, employees, federal government, state government, nobody can afford healthcare. If we don't change the economics of healthcare, we're going to have just an even worse problem 5 and 10 years from now. So let's hope that population health and value begins to catch on in a larger way.
Terry, do you want to add to that?
Yeah, I'm thinking about the word hope, and I'm thinking that we need strategy, and everybody would agree with that. Two groups come to mind that I also want to just call out in this conversation, and one is AARP and everything that Sarah Locke is doing as they lead the Global Brain Health Initiative, and the number of resources that are available and to the public in that work, and also to advance what needs to happen in society. Certainly the National Institute on Aging, with its $3 billion annual budget, maybe it'll be higher next year, is making great inroads in thinking about not only the science of curing Alzheimer's and related dementias, which is so important, but also the caregiving strategies. And I know that Richard and his team are really working hard on that. The other group I want to point out is the Milken Institute for Aging under the leadership of Nora Super, where she also has a brain health initiative. And all of these come together to be a more powerful force to make sure that the public knows what these strategies are, what we should ask Congress for, what we should be asking a next administration, what are the different features that we would like our state government to be really focused on. So those are some of the things we have to do now.
I think as advocacy groups, we have our Be Brain Powerful campaign by the Women Against Alzheimer's, and we are really following the research because it needs a different conversation. This is a conversation about empowerment and what you can do to stay healthy as you age. So I think it's really critical. We have a question from our audience, Dr. Davis. And again, it's obviously a concern for someone with a loved one who has probably had the disease. Can you discuss any special protocols that are taken for COVID patients with dementia? Many are scared, confused, especially with all that protective gear that providers have to wear.
The protocols, whether you have dementia or whether you don't have dementia, are the same. It's the convalescent plasma, antibody treatment, remdesivir, dexamethasone, anticoagulants, they're appropriate. It doesn't matter. Everyone's treated the same way at this juncture. We have no reason to suspect that it should be any different. The longer term question is, so once those patients recover from COVID, but have the added burden perhaps of mental fog on top of their Alzheimer's disease, what do we do then? And We don't know the answer to that question. We're just going to continue to give the Alzheimer's drugs and hope that that mental fog diminishes.
Can you describe what brain fog is like?
It's totally different in almost everybody. And the reason for that is because this disease doesn't just affect the memory part of the brain, the part that encodes new information. This disease can affect lots of parts of the brain. So whether it's a concentration problem, an attention problem, a word finding problem, a long-term memory problem, a coordination problem, it all depends on what part of the brain got inflamed or what part of the brain wound up with tiny little.
Let's look at what COVID has done, Mr. Walker, to our lives. We're here virtually. We would have been in person before. What do you see as the promise for telehealth? It was discussed earlier in our summit, but relating to dementia-related aging. And I only ask that because it's assumptive that the communities you serve have access to the virtual services.
Yes, what we've seen is an expansion in terms of telehealth and acknowledgement that telehealth is a key component, and that we're very pleased that Medicare is now paying for telehealth visits of all types. We are pleased that of the responsiveness. We've seen how important that really is, but we've also seen, and this relates to rural areas as well, in particular, where virtual programming is just necessary during this time. We're pleased that our entire aging services network and all the programs that we've operated, many which have to date been very hands-on, direct contact programs and services, we found ways to do them virtually, ways we would have never even dreamed of before. And that means the ability to reach into remote areas, frontier areas. Now, there's a challenge there too, because we acknowledge that we've had broadband issues, which it looks like I may be having right now, but broadband and internet issues. But we've worked with the FCC to make internet tools, cell phones available, and to broaden the concept of broadband throughout the country. But we're just excited and pleased about how much telehealth has been broadened at a time when we need it most. And we think it will set the stage for the future. Many of the things that we're doing now virtually, we think that we will continue to do that. I've heard that universally from every component of our aging services network, that it's making them rethink their entire operations and that they will be effective in providing services in a remote way. For caregivers, it will be even more convenient because in-person programming that they used to have to carry or take an individual to, now they will be able to receive those services in their home, remotely, on their own timetable. And so we see this as a win-win all the way around.
Dr. Fulmer, predictions are that there will be a workforce shortage of caregivers. We've discussed telehealth, but what is your view of apps and avatars and robots? At first I laughed and was offended, but who knows in this world?
Yeah, thanks, Meryl. And I mean, I'm a very big proponent of all the different technologic solutions that we can bring to bear on caregiving for older adults and on solutions for older adults. Let's face it, it's a lot more humane, going to Edwin's point, it's much more humane, whether you're in Manhattan or whether you're upstate New York, where I am right now, to have a person do remote telehealth. Here's a story that was so poignant to me. I was working as a geriatric nurse practitioner, and that afternoon we had set up a clinic, a GYN clinic for older women, and I do mean geriatric women. And they came to the hospital, and they came in ambulance. This was an urban setting. And we got all these frail, disabled, older people up to the clinic. And in fact, that day, there had not been a delivery of the equipment needed to give them care. So they all had to go home. And never was I so, my heart broke for these people who had struggled to get there. So fast forward, I'm upstate New York. I am a member of the Bassett Medical Center Board. Our health system covers 6,000 square miles upstate New York. And all it has to do is snow one day and everybody's healthcare is completely dismantled. Well, now we have a new day. And so I just add two other groups. The American Telehealth Association is a very powerful resource to all of us as they use their capacity in Washington to make permanent changes to telehealth and telecare. And the other group I want to comment on very briefly is the MIT Age Lab, where Joe Coughlin has really done a lot of exciting work on ways in which we can use self-driving cars, and even the simple little things like the robotic cats and dogs. We had an earlier conversation about pets, but these robotic cats and dogs are shown to decrease anxiety in older adults who have memory problems or dementia, and they're shown to be very effective. So we have to use every strategy that we can. A lot of people are keen on sensors, and I think that it's going to be also very important to pay attention to the older adults' preferences. How would they have felt if they had a sensor on them or a camera on them? If you were going to use substituted judgment, is that something they would have been okay with or not? We've got all that in front of us.
We only have about 8 minutes left. And Dr. Davis, I really would like to move on to the vaccines. I mean, there are 170 candidate vaccines being tracked by the World Health Organization. Experts say that they'll be available for vulnerable populations. Our A-list seems more interested in getting them the vaccines for their loved ones. What is the conversation that doctors and nurses have with families, with loved ones, with advancing dementia on whether to have a vaccine or not treat?
So these are tough questions. We hope that within a month or two, there'll be approval of either the Moderna vaccine or the Pfizer vaccine. What we don't know is how efficacious they will be, particularly in older people. So we have to get a hard look at what the efficacy is before we make a recommendation. Remember, these vaccines have to decrease the frequency of COVID infection by some 60% over placebo to be approved, at least by the regulations that we've so far said. But that's over a large population. What does that mean for people over 65 or 70 or 80? We're really going to have to dig down and find out and make a decision about whether it's really worth it. If hopefully the safety of these vaccines will be real, and we won't have to worry about that side of the equation, but we'll only have to worry about efficacy. Our group is meeting almost as we speak now to develop protocols for how will we deliver this, where will we deliver it, who will we deliver it to. We're getting some guidance from our state, which is listening to what we've heard from the feds, and clearly we're going to be targeting at-risk populations and healthcare workers, frontline workers. And that will be the first round. So who are the high-risk populations? Elderly people, particularly elderly people with comorbidities. So we can anticipate that those will be the first line to get what drug, what vaccine will be available.
Thank you. We're out of time, but my final question is something that George actually asked of the governor. If you could orchestrate one or two changes to ensure we're better protecting families facing this looming Alzheimer's epidemic, what would it be? Did I stump my panel? What?
Meryl, I can start and say that families need to know that they have a healthcare system and a public health system that will be there for them. They need to, there's been some confusing messaging. They need clear messages, clear communication, and they need direction. And so I know that we've got a lot of great leadership in this country that's doing that, but we can do better. Everybody has to also trust. We have to rebuild trust and make sure that families feel that they're getting a straight answer and that they are getting good direction.
Mr. Walker?
I couldn't agree more with Terry. In fact, it's almost identical to what I was thinking in terms of it's very unfortunate, and this relates to the vaccine question as well. It's very unfortunate that there are all of these conflicting messages, and it has resulted in a high degree of reluctance to even take a vaccine. And it's really important to stress appropriate safeguards and appropriate protocols, just as Dr. Davis did, in order to build that trust or rebuild trust in this country. And you can take that example and apply it to the entire area of caring for or addressing the issues of Alzheimer's disease. The issue for us is getting more people, policymakers, appropriators, to truly understand the issue, the challenges. One problem is that most people don't think about this until they have it as a personal experience in their own lives and families. And we don't want that for everyone. We want people to understand long before then about the challenges of long-term care, and particularly Alzheimer's disease and dementia.
Dr. Davis?
You know, there's very little I can add to what my colleagues have said, but I'd make this point. As effective as we have been in advocacy, we have to understand that there's much, much more to do in that line. The epidemic that will be the baby boomers reaching the high risk for Alzheimer's disease age would essentially cost more money to Medicare right now than the entire Medicare budget is currently. We need to address that, and we need to address that with research and science and investing much more money in multiple approaches to prevention and treatment. As much as we think we've done a good job of enhancing that NIA budget, it's still grossly inadequate to the epidemic that we're about to face.
And can you just do a shout out for participation by our communities of color in your research and why it's so important?
Well, Mount Sinai lives on the juxtaposition of the richest and poorest zip codes in America. We provide the same care to everyone. So when we see the disadvantages that happen to our minority populations, it's painful to an extreme. So in our centers, we try to do everything we can to include minorities in all our studies and in all our work, because we know how critical it is to have a largest possible population for anything that we do.
Thank you all for joining us. By the way, Terry, AARP is being celebrated tonight at our gala. So nice. Good collaborations. Thank you, Mr. Walker. Thank you so much, Dr. Davis, for joining us. And thank you for the work you do both in research and on the front lines of our care. I'm now going to turn the program back over to our fearless leader, George Friedenberg. Thank you.
Thanks to that rather extraordinary panel of people on the front lines who are really getting at the tough problems at the intersection of COVID and Alzheimer's. It was very impressive. People living in the dementia community, living with the disease, their caregivers, their loved ones more generally, has been at the center of our work. And Meryl has been, as a caregiver herself for 24 years, sort of at the forefront of forcing us to make sure that we talk to, listen to, most importantly, listen to those living with the disease and caregivers. She pressed us hard to develop something called the A-List. The A-List is now an online panel of 10,000 caregivers and persons with dementia, or those that fear dementia because they might have the pathology. And as a consequence, we take a pulse of that community regularly, at least once a month, if not more frequently, to understand what are they caring about today, this week, next week. And the answer consistently over the last 6 months has been COVID, for all the reasons that panel and Meryl have discussed in the last hour. Separation, isolation, increasing cognitive decline, rapidity of decline, deaths. It has been devastating to our community, and to particularly those elements of our community who are people of color, communities of color. Now, both Ken and Governor Lujan Grisham outlined a vision of how it is that we ought to transform our health system into one that is viewed as going there when you have acute instance, acute disease, or a broken bone, or some other element of your physical body that needs fixing, and beginning to transform it to include prevention, anticipation of disease, risk factors for disease, prevention measures, whether that be increased attention on an individualized basis to risk factors for your brain health and for related diseases. And therefore, opening up the possibility that we can adopt a national prevention plan that will begin to transform our health system into one that recognizes and cures, treats, or prevents brain impairments in later age. That is one of our goals. The other thing it does is to begin to identify those people at risk or those people at the very earliest stages of symptomatic disease with whom we can work to target new therapies that are coming down the road that are either designed to slow the disease or potentially stop the disease and stop it before you get symptomatic. Much like HIV/AIDS, where we can hold people at an HIV positive level, but nevertheless not have them get full-blown AIDS and have those individuals with HIV live a life of equal to in length, potentially equal to in health, without ever getting the vaccine. We've been struggling for the vaccine for 20 years and haven't gotten it in HIV, but we're on a path with HIV where HIV patients can live with chronic disease and not necessarily be symptomatic. That is our goal here. Our goal is to introduce therapeutics and lifestyle prevention measures and management of risk factors for the disease, which will enable you to stay non-symptomatic for a very long period of time and hopefully never experience symptomatic Alzheimer's. So you've heard over the last couple of days how we work. We work with Us Against Alzheimer's. We work with researchers, with government, with pharmaceutical companies, with NGOs. Terry Fulmer leads one of the best that is focused on this disease. And so we work with everyone we can with common goals and missions, with common strategies, dividing out who is going to do what in order to achieve some common goal. That's why we advocated for and were able to get a goal to stop Alzheimer's by 2025. That's why we are now working to develop a large-scale coalition with the Heart Association, the Diabetes Association, YMCA, AARP, Milken, to get a national prevention goal so that we can begin, with respect to brain health, to turn the ship to a much more prevention-oriented world, the kind that Governor Lujan Grisham outlined. But as we do that, we must take account of the acknowledged existing racial, ethnic, and economic disparities that exist in this country for chronic diseases and for the disease that we are focused on, which is dementia. So we have to look at what is causing those disparities and participate with others who are working on racial disparities that exist in finance, the racial disparities that exist in policing. But we have a slice that says we want to work with everyone who is working to eliminate disparities in healthcare, both access to research, clinical trials, but also to treatments as they come forth. So as Governor Lujan Grisham mentioned, working potentially with her community health centers and potentially more resource from the federal government to enable her to begin to turn this ship called our health system into one that treats people equally across race and across national origin and across economic inequalities and gets the capillaries of our traditional healthcare system out into communities. We've heard from a lot of players and about what gives them hope. And hope is very much the theme that I'd like to leave you all with, which is we are on the cusp of some real therapeutic breakthroughs in Alzheimer's. They are just the start. the first drug out of the gate for HIV, the first effort in cancer, we're not where we are today. But we are about to start with new therapies. And that therapy will be sort of novel for the health system because doctors have not been systematically trained in brain health care and be able to detect early and to diagnose differentially in order to understand how to treat and prevent potentially brain health impairments. But hope is here. National prevention goal, new therapeutics, all on it. Leaving this summit, we got to understand that our fight against this devil disease continues. Please join us in that fight. Sign on as a supporter of the national prevention goal. Join us with your ideas and your connections on the whole collaborative network that we have to create to mitigate and then eliminate the racial disparities in health systems and clinical research. Join us to advocate for Congress to increase research funding for cognitive health screenings and for earlier interventions to stop this disease. Join us for our Be Brain Powerful campaign and take the 30-day challenge to improve your brain health. Tell your friends. Anticipate that there are going to be significant new investments in our Be Brain Powerful campaign to enable people to get increasing insights into how to maintain their brain health and to be able to actually measure whether or not their brain health has been maintained or improved as a result of these interventions. More to come on that score. Help us by joining the A-list. If you're a person living with dementia, concerned about it, or a caregiver, join the A-list, participate in our online surveys so that we hear from you what's on your mind so that we can turn what's on your mind into action. As we heard so much about COVID and the danger in nursing homes well before it was covered in the press through our A-list surveys, we turned our attention to advocate with the administration to get a much more focused effort in testing in nursing homes. Now, the federal government turned that back to the states, but nevertheless, action was taken by the federal government, at least to focus on the subject as a result of the A-list survey. So sign up for the A-list. Nevertheless, if you haven't done so yet, vote. Make your voice heard politically, which we are not a Republican or a Democratic organization, as you've heard. We're an Alzheimer's party. We are an Alzheimer's organization. So vote for the candidate you believe will do the best job for our community. Our community is large, it's growing. It largely has not been heard of, but my own political giving always is aimed at which candidate is going to be more effective in fighting for Alzheimer's resources and Alzheimer's policy, pro-Alzheimer's, anti-Alzheimer's policies. So hope is on the horizon. We have potential of 3 drugs on market from now. And I believe in the next few years, we're going to have more drugs and real likelihood we're going to be able by 2025 to come close to, if not hit, our national goal of finding a means of prevention and effective treatment for Alzheimer's. As we end our 2020 summit, I really do want to thank all the advocates and supporters. I want to thank everyone who attending. Around 12,000 people attended yesterday. I don't know what the numbers will show for today, but this is a very large community clearly interested in the problems and the potential solutions and how to get involved. I want to thank the Us Against Alzheimer's team. They have adjusted to COVID like no one you believe. They're working tirelessly. We have not missed a beat substantively in our own work because so many of our team members work at home, can work at home, and participate in a large number of Zoom calls, but nevertheless have been just as effective in the COVID world as not, even though they have the extra burden potentially of either husbands at home, wives at home, or children at home, which require increased attention. So I want to thank them for that. But I also want to thank them for adjusting this summit from what was planned to be an in-person summit, which in many ways is simpler, maybe, but it does not reach as many people. And so that they pivoted. If for those of you who are joining our gala tonight, and I will describe it in just a second, you will see that my house has been turned into a television studio. So much of tonight's gala will be live from my house in Washington, D.C. But this is a team that pivoted from an in-person summit to a virtual summit. And we have a team tonight that's focused on our gala, honoring Mandy Moore and others, to a virtual gala. And so we have close to 1,000 people attending the gala tonight from around the country, from 30 different states. I want to thank the sponsors of the summit for tonight's Trish Vredenberg Gala. In fact, thanks to the very generous sponsors of the 7th annual Trish Vredenberg Gala, we're able to make the live broadcast of the gala available tonight to all of our friends and advocates. So join us. The gala begins at 7:30. You can attend by going to usagainstalzheimers.org/gala on your screen. Singer, actress, advocate Mandy Moore, who stars in the program called This Is Us. She plays Rebecca Pearson on a program that goes out to 6 million people a week, 6.9 million people a week. As a matriarch of a family who's been diagnosed with Alzheimer's. And you will see how other members of that family react in the TV show to her experiencing Alzheimer's. Some in denial, some want to go out and nail the disease to the wall and to become advocates. Others turn into caregivers. There's a variety of reactions that mirrors what happens in the real world when the matriarch of the family gets Alzheimer's, which has happened to my family now 2 generations. Now we have a 3rd generation as well. So 3 generations of my family over 40 years, that's enough. So I hope you all will join us at 7:30 tonight for the gala. We're going to end this summit with a video of comments from caregivers, families, supporters, partners, and friends, all sharing who they are fighting for. Their stories remind me of why we launched this organization 10 years ago this month, why we will never stop in this fight until we put a dagger through the heart of this cursed disease. Thank you for joining us. Enjoy the video. I'll be back right after the video for a final comment. Thank you.
I am fighting for all the caregivers across the nation who are working tirelessly around the clock to take care of their loved ones while also balancing their health.
I'm fighting for people like myself who are living with Alzheimer's or a related dementia.
I am fighting for all, so no one else must live this dreadful disease.
If there was no Alzheimer's, there would be millions of people who would still be able to hug their mom, their dad, their grandma, their grandpa, and I'm fighting for those people so that they can continue hugging them.
Tonight, we're fighting for a care and a cure in memory of the 8 family members for whom we and our immediate families cared, who either had Alzheimer's disease or vascular dementia.
I'm fighting for the possibility to spread happiness despite having this disease.
I am fighting for a future we can all remember.
I'm fighting in memory of my father, Vic Coda, who we lost this past July to dementia.
And I'm fighting for a cure in honor of my dad, who died of AD 3 years ago.
I'm fighting for a world without Alzheimer's for all communities, regardless of race, ethnicity, gender, sexual orientation, or zip code.
I am fighting for my grandparents who I have cared for, and for all other millennials and Gen Zs who will disproportionately bear the burden of Alzheimer's.
I'm fighting for my mom, my dad, my father-in-law, who all died with dementia.
I'm fighting for the right to have my body not outlive my mind.
Studies suggest that Latinos in the U.S. are 1.5 times more likely to develop Alzheimer's disease than white non-Latinos. If there was no Alzheimer's, our abuelitos would live a better quality of life. They are whom I'm fighting for.
I fight in memory of my mother and father, and in honor of all those people who made my parents struggle with dementia just a little bit easier.
I am fighting for my grandfather who suffered from dementia.
but also for the almost 6 million people suffering from the disease in the US and the over 15 million unpaid family caregivers.
I am fighting in memory of my parents.
We are fighting for my mom and all those who live with this disease. We need more research. We need more resources and tools to support people living with all forms of dementia and their family caregivers.
3 generations of my family over 40 years, I'm fighting against this disease for my kids and my grandkids. Join us. So what you've just seen in the last couple minutes is the us in Us Against Alzheimer's. We invite all of you to join us. We thank you all for attending this summit, and we look forward to working with all of you in the months and years ahead. Thank you very much.